Good morning. Welcome to the December 17th Public Health Nursing ITV, and happy holidays where you are from Frankfurt. We have a very full agenda today. I think we've got 9 different speakers, 10 different speakers coming and revolving through the presentation and the agenda today. So I'm so glad you could join us. Please let your team members know, your regional EPIs know that if they weren't able to join us today for the live presentation, this session, as always, will be archived for viewing at a later date. My name's Joy Hoskins, and I'm the Chief Nursing Officer for the Department for Public Health, for those of you all who don't know me. And it's my pleasure this morning to introduce Dr. Artis Hoven, who is a medical consultant with the Department for Public Health in our Division of Epidemiology and Health Planning. I have Dr. Hoven's resume here, her CV here with me, and we're so fortunate to have Dr. Hoven be a part of our DPH team. And for those of you all who may have had the opportunity to communicate or interact with Dr. Hoven, I'm sure you'll agree with me what an asset she is to our team. Dr. Hoven is currently also with the University of Kentucky College of Medicine. She is the past president of the American Medical Association, and she also is the chair of council for the World Medical Association. So there's no one else in this building, in this cabinet, that has those types of credentials. So again, we are very fortunate to have Dr. Hoven with us today. She's going to be speaking about hepatitis C, and as you all may know, that there's a new chapter in the CCSG that was released last week. And so Dr. Hoven's going to be presenting an overview of the epidemiology of hepatitis C, the morbidity and mortality information, how it relates to in Kentucky and the United States, and as far as the indications for screening, treatment, referrals, and so she's got a wealth of information to share with us today. So with that, I'll turn the camera over to Dr. Hoven, and you all may notice that we're in a different room today taping, so hopefully we'll be able to have the technology piece that we didn't unfortunately have upstairs. Hopefully we'll be able to have a better quality taping and review and archive version for you all today. So Dr. Hoven, thank you for joining us this morning. And
Thank you, and good morning to everyone. I'm delighted to be here. This is a new experience for me. I've learned a lot. It's like drinking out of a fire hose, and I'm getting accustomed to it, but I still have a lot of learning to do. This session this morning, I think, is particularly timely. It's extremely important, and I want to spend a few minutes before we get into my PowerPoint presentation talking about the why of we are doing this particular work now on hepatitis C screening and testing. About 2.2 to 3.2 million people in the United States live with chronic active hepatitis C infection. That's about 1.2% of the United States population. In Kentucky, if you extrapolate from that, both urban and rural populations, we're talking about 50 to 53,000 people living in Kentucky who are infected with hepatitis C. Kentucky leads the nation in the number of new acute hepatitis C cases. That's really scary information. The epidemic of IV drug use has clearly accelerated this very serious situation in our state. And unlike hepatitis B, there is no vaccine to prevent the infection. As many of you may know, the Indiana State Department of Health and the CDC are currently investigating a large outbreak of recent HIV infection among persons who inject drugs. They have learned that about 90% of the nearly 200 cases are co-infected with hepatitis C. On a different note, and of equal concern, is that in our younger drug-using population is the woman of childbearing age who becomes pregnant and the potential for maternal-infant vertical transmission. In Kentucky, as of October 2015, over 900 reports of pregnant women with hepatitis C positive antibody have been received. We have an epidemic.
Whoever just came on, your microphone's on right now.
Sorry.
So as I just said, we have an epidemic, and welcome to whomever came on. The good news is
Hello,
that...
welcome to the conferencing system.
To join a conference, you may use the far end.
Okay, all right. Good news. There are now excellent oral therapies that are very excellent in terms of curing hepatitis C. The problem is the cost of this is extremely high. Currently about $86,000 per treatment course. And the course of treatment lasts about 8 to 12 weeks. This is compared to what we did several years ago, in which we were having to use interferon and ribavirin, and the patients tolerated it poorly and the outcomes were not very good. So I tell you this because we have to talk about prevention of hepatitis C in this state. Those folks walking around with active disease, be it either acute or chronic, with measurable virus in their blood, are at high risk of transmitting this infection to those with whom they come in contact. And we'll talk about the risks of how they may be transmitting this infection. So our job in prevention and in public health is to identify those that are infected, educate about the disease and the transmission of disease, and work collaboratively with our other partners in the healthcare community as to how we are now going to manage this particular epidemic in our state. Before I go on, I want to give a shout out to two people who have done the heavy lifting in the work on this, Kathy Sanders and Dr. Rob Brawley. They have done an amazing job of putting this together. They're both traveling, thus unable to be here today, and I am simply their messenger. So they have done a yeoman's job of delivering the work product here, and we all should be very, very grateful for that. So let us start now with our slide set. Let us move on now to some basic information about, again, some more whys and hows. The Kentucky Department for Public Health encourages all local health departments to begin offering hepatitis C virus, HCV, education, prevention, screening, and testing to all identified at-risk persons. We want to offer HCV screening and testing services during all healthcare encounters when persons are identified at risk. So what is it? What are we talking about here? HCV is a blood-borne disease. It is transmitted primarily through large or repeated percutaneous needle sticks, sharing needles, passage through the skin, exposure to infected blood. It is primarily spread through intravenous drug use. However, it can be spread in other ways from contaminated blood. Most of the time, it's a chronic viral infection with few early symptoms. And in fact, someone can become infected and may have minimal symptoms. It may be very mild, something that they wouldn't even pay attention to. A bit of nausea, maybe a low-grade fever, some malaise, nothing particularly enlightening. And unfortunately, the simple danger signs of advanced HCV don't appear for up to decades after the person has become infected. HCV becomes chronic in approximately 75 to 85% of the cases. What that means is only about a fourth of the people are going to recover from it spontaneously on their own. Chronic infection leads to liver scarring and fibrosis, liver cancer, or total liver failure. And it is the leading indication for liver transplants in the United States today. Acute hepatitis C rates have dramatically increased in both rural and urban communities. You know, for a long time it was thought to be an urban problem, but now it's both rural and urban. In 2013, reported incidence rates rose to an alarming 5.1 cases per 100,000. And between 2009 and 2013, reported rates of acute hepatitis C increased by 240% here in Kentucky. If you use that 240% talking about any other situation in our country, people would be absolutely flabbergasted. Well, this is the situation here. We all have to be flabbergasted about this, and we have to be conscious of the fact that this is something we have to take control of in any way that we can. Here's a slide that points to the number of acute Hep C cases from 2005 to 2014. You can see those nice little green lines have been progressing upward, and they will continue to progress upward unless we identify ways of stopping this epidemic and work on prevention issues. So what we're going to talk about today, the Kentucky hepatitis C virus antibody screening and confirmation with HCV RNA quantitative testing program guidance. That's the headliner here on the documents that you have received and have access to via the CCSG and all the other things that Joy and her team have done to make it available to you. I think this is also going to be posted to the website, if I'm not incorrect. Is that correct, Joy? Very good. So I encourage you to make this full-time reading for a while, because this is an imperative, I think, for healthcare in Kentucky. We recommend that the local health departments now proceed to use venipuncture to obtain the specimens for HCV antibody testing. We're talking about blood test via a blood stick, a venipuncture. The HCV, and I'm going to you're going to hear me speak periodically about two different types of testing, but I want to reiterate right on the front end of this is that the rapid test, not the venipuncture test, but the rapid test, should only be used for HCV off-site outreach and or syringe exchange programs. I think we have somebody with their mics on.
Excuse me, someone has their mic open. Could you please check your mic and put it on mute, please? Thank you.
Thank you. Again, let me say that again. This program that we are jettisoning today is in fact for venipunctures to obtain the specimens for HCV antibody testing. Rapid test HCV testing should only be used for HCV off-site outreach and or syringe exchange programs, and we can talk more about this later. Oh, we're actually going to talk about it right now. HCV outreach and syringe exchange programs, everybody knows what I'm talking about here, I assume. We're also talking about, for example, if you did some work in a Suboxone clinic, or you went to an area where you knew you had a high-risk gathering of individuals, that would be the place that you would begin to do the rapid testing. Some observations and recommendations. Training on the HCV rapid until you have, actually the training has to occur before you can do the testing. You have to have testing and you have to be qualified to do this. And you can get this training by contacting the rapid test actual manufacturer, and that information we can provide to you. Any outreach or syringe exchange program using the HCV rapid must have a quality control plan. They will tell you how to do it. It has to be in place. It has to be done regularly, and I would encourage you to stick to that very closely. And those quality plans can be reviewed by the laboratory here in DLS as well for the health department. The rapid test, the test kits and controls have a defined shelf life and must not be used beyond their expiration dates. The rapid tests have defined storage and temperature guidelines that must be followed. Like any rapid test, whether it's for HIV or hepatitis C, you gotta play by the rule book. You can't stick something in the trunk of your car and let it sit there in 100-degree heat for 5 hours and expect it to promote a valid test response. So please pay attention when you're doing these outreach programs to be sure that you are following the guidelines. And I am not making this up. That has actually been done before. So I would just caution you about getting it right and doing it the correct way. So let me tell you how to participate in this program before we move on. Kathy Sanders, as I said before, has been the lead person in this. Kathy is extremely knowledgeable, very approachable, and very able to provide you the kinds of information that you're going to need. You can also contact the laboratory, the lab kits, via kentucky.gov. You see that information there to order the test tubes that are going to be required, the shipping and collection information, as we now move into the discussion on the venipuncture and the serum testing that will be made available. The other challenges we're going to have are identifying linkage to care in your various regions to ensure that the patient gets evaluated for care for their HCV positive results. And this is one of the challenges. We have talked endlessly about this because we are very concerned about the lack of adequate numbers of providers of health care to deliver the care to these individuals. What are we going to do about it? But you know, unless we start talking about it and unless we start dealing with the challenges, nothing is going to happen. We are going to depend on you all to help us with feedback, with information. Who are the providers out there willing to help take care of these individuals, to evaluate them, to screen them, to see if they qualify for therapy, and so forth and so on. And so I would ask that you report back to us, report back to Kathy. Let us learn more, because if we don't do this, we are not going to gain the proper ground that we need to gain in the discussion. You need to identify within your departments and those individuals who will be doing the screening, the educating, and testing, and be sure they are up to date and knowledgeable about this. Kathy, Dr. Brawley, myself, any of us here in Frankfurt are willing to do whatever we need to do to educate and help people understand the process. Our training, the training should include confidentiality training. You're used to that with the HIV work. Staff training on HCV infection and what it is and who is at risk, and the ability to provide HCV screening, education, and testing. So let's move on to what I consider probably one of the most important discussions we're having here, which is about who should be tested. Persons who have currently been injecting or using intranasal drugs. Why is intranasal on there? Well, if they're using intranasal, they're probably injecting at the same time and vice versa. They're not purists when it comes to how they get their drugs, so remember that. If someone ever injected drugs, including those who injected or used intranasally once or only a few times many years ago, and here we're talking about the baby boomers, the 45 to 65 years old who did it and nobody knew, or they thought nobody knew. And you've got to ask the questions very delicately. People who attend unregulated body piercing or tattoo parlors. Now, personally, I break out in hives when I drive past a tattoo parlor, but there are some people that don't. They also call these scratchers, people who get their tattoos by someone else scratching on them, who may contaminate them with a dirty needle. So ask about scratchers as well. That was a term I learned when I came to the health department, actually. I'd never heard it before. Sexual contact with a known HCV positive person. Now, sexual contact is lower risk. It's low risk for heterosexual partners. It's higher with men having sex with men, but the potential still exists. Someone with a history of a sexually transmitted infection. If they've had history of syphilis, gonorrhea, HIV, obviously they are at risk for hepatitis C as well. History of incarceration. I think we have learned the hard way that those individuals who are incarcerated have an increased risk of everything, including hepatitis C and HIV. And again, the baby boomers, adults born during the years 1945 through 1965, they should at least be tested once without any prior ascertainment of HCV risk factors. I think that's going to be a little hard to pull off, actually. I think you ask these folks, should they present to you for testing? But they should at least be tested once to find out. If they have no ongoing risk factors, they should be at least tested once to see if they have chronic hepatitis C infection. I'm sure as you've been watching the television or looking at any magazines, you see these really cool ads on TV. They're elegant people. They are in amazing places. They look wonderful with hepatitis C. And what you're seeing is the drug companies now reaching out to the baby boomers, because these are the folks that appear to be, or we thought were the only risks for hep C, but in fact we're finding, particularly here in Kentucky, that the ages are even less than that. But keep that on your radar screen as you're evaluating these patients. Others should be persons who have certain medical conditions. People who received clotting factor concentrates produced before 1987. That's pretty far long ago, but still you have to find that out. Ever on long-term hemodialysis. Again, high risk there. People with persistently abnormal ALT levels, one of the liver function enzymes that we measure. People who have had HIV infection, who have it right now, and people who might be co-infected with hepatitis B. So again, those folks should be tested as well. Persons who were prior recipients of transfusions or organ transplants, who were notified that they received blood from a donor who later tested positive for HCV infection, or received a transfusion of blood or blood components of an organ transplant before the year 1992. My guess is that those individuals are probably circulating around in a healthcare delivery system, will probably have been tested, but you know, you have to be prepared, and you might not know what they have been asked prior. People with recognized exposure, including healthcare personnel, emergency medical personnel, public safety workers, after needle stick, sharps, or mucosal exposure to HCV positive blood. And as I mentioned much earlier, children born to HCV positive women. And right now, we're just on the learning curve about what's happening to these pregnant moms and these babies. There's a lot of information we need to understand this better, we need to understand how we're going to intervene, so this is very important for us to do. Included in your material packages will be the educational materials, and the guide itself, which is full of really good information, and I would encourage you to spend some time poring over it. Don't read it at bedtime. Read it after your first cup of coffee in the morning, so that you will remember what you have read. It's going to be very important. So we're going to be performing high-risk screening. We should refer individuals identified with HCV risk factors who have health insurance coverage that will cover the HCV test cost to a private provider for anti-HCV testing and follow-up. This is very important. And you may have some folks come to you and say, I'm a baby boomer or blah, blah, blah. You need to find out if they have private health insurance. If they do, they need to be referred to that provider to have their testing done and the follow-up arranged as well. If an individual identified with HCV risk is uninsured or has insurance that will not pay the cost of the HCV test, that's the group I want you to offer the HCV testing to. I want everybody to have HCV testing, but you know, we have to be frugal. And this is not inexpensive to do. Many of these folks at risk have insurance coverage that are now in Medicaid. Let's use those providers. Let's use that insurance coverage to get them the testing that they absolutely need. So as some of this is duplicative, but that's intentional. You need to go to that email site to obtain the tubes that will be necessary. As I understand it, every health department in the state already has centrifuges, to spin down the blood. You need someone who is qualified in doing venipunctures to collect the specimens. You collect a specimen using a 1/8.5, I'm not sure what that means, PPT tube. Purple, is that the purple top tube? Plasma prep. Are you the laboratory lady?
Yes.
Oh, wonderful. Yes. A purple plasma tube, okay?
Plasma preparation tube, it's a white cap.
White cap plasma preparation tube, okay?
I lied.
You lie, oh, sorry, okay. You spin the tube using the centrifuge within 6 hours of collection. Remember my admonition about things in the trunk of the car? Same admonition here, pay attention to timing. You should have at least 3 cc's of plasma at the end of this. You're going to send it to Kentucky DSL using overnight mailing system with an ice packs. And we have someone here from the laboratory today who can answer specific questions about that. Specimens collected on Friday should be frozen and sent in overnight mailing the following work day. So let's spend a few minutes talking about, okay, now what do? I get this report back. A non-reactive HCV antibody result indicates no HCV antibody detected. False negatives rarely occur. HCV infection can be detected by screening tests 4 to 10 weeks after the infection occurs. That means because antibody has to develop to the virus itself. The antibody can be detected in greater than 97% of persons by 6 months of exposure. We know that that first 6 months after exposure, the infected individual will have circulating virus off and on. It may be undetectable periodically, but by the time they get to 6 months, they will have identifiable antibody in their blood. And a reactive HCV antibody result indicates one of the following: a current HCV infection, a past HCV infection that has resolved, or a false positive result. So one of the questions I get asked a lot is, what can be a false positive HCV antibody result? False positives occur when there are other competing antibodies circulating in the blood. For example, pregnancy. Multiple pregnancies can be associated with a false positive test. People that receive lots of immunizations. People that have had parasite infections, for example. We have seen that occur as well. There are some folks who have immunological disorders such as lupus, which can have false positives. And so it could be a false positive in someone who has absolutely no risk factors, who has a positive hep C antibody. You need to try to figure out ahead of time so that you're prepared to handle how you're going to talk with this patient. That's why we do, however, the RNA confirmation. What we are actually doing is measuring the amount of virus circulating in the blood in that individual. Automatically, when that test is processed at the laboratory, if that antibody test is positive, the laboratory will automatically reflex it. They will automatically, and you don't have to do anything, the laboratory will automatically do the confirmatory test, which will be a measurement of the viral load of the virus in that specimen. This is an RNA virus. That RNA virus appears in the blood and can be detected as early as 2 to 3 weeks after that individual has become infected. That's why we really like to do viral loads, because they're really very confirmatory. There's nothing that can interfere with the viral load determination. So you will have a log. It's in one of the appendices attached to the document, and we're going to ask that you report and mail and email us the data analysis on a monthly basis, depending on what information you have obtained. We're also going to ask that you report on the HCV counseling and referral so that we can get a sense of who's being tested, where they're being referred, are they being treated, and what sort of supportive services do you see appearing that are going to be necessary? I am a firm believer in the fact that if you don't stick your neck out, you're not going to know where the smell's coming from. And so you've got to figure out kind of what the needs are in the communities to know what we have to do to, get this progressing.
Dr. Hogan, I just wanted to share with the nurse leaders that the log, the patient information log, will be found in the form section of the CCSG. It's form number 3. Okay.
Thank you very much. I am new to CCSG. I am new to the forms. Joy is trying to guide me through this, and Dr. White as well, and it's been a bit traumatic, but I'm learning. Okay. And anytime...
I might ask, is that similar to the form that local health departments used during the pilot project?
Yes, sir.
Occurred?
Yes. Yeah. So that form, Kathy adapted from the pilot program, the HCV testing pilot program that was previously implemented in several of the local health departments. So I think there were a few tweaks and adjustments for that. Yes, but particularly for those who participated in the pilot program, they'll be familiar with that form and how to submit that information. So it's a very similar process.
Great, thank you all. I hope everybody heard that. So if you didn't ask it later, and Joy or Dr. Humbaugh or someone else can identify how you're supposed to do this. Again, as always, we're willing to do any assistance with data management from your and assisting with work from our regional epidemiologists, and I would encourage you to be engaged with them as well. Now, this is where this is going to get, I think, a little more difficult. And this is why we are asking your support and help and advice as we move through this. Anyone with a confirmed HCV RNA infection, now remember they will have had a positive antibody and a positive viral load in the specimen that has been submitted, should be evaluated for referral or consultation for the presence of chronic liver disease. Now, you may, in fact, pick up someone with acute hepatitis C. We call them acute for up to about 6 months after the time that they have been exposed. And during that period of time, they will develop antibody, they will have circulating viral load, but it will be too early to really assess any potential damage. I mean, they will have it, many of them will have abnormal liver function studies, but at that time they may have acute hepatitis C. We do not provide antiviral therapy for acute hepatitis C at the present time. That may change. I think with the new drugs being out there and recognizing the potential for controlling this process, that may change, because we do know that about 1/4 of these people are going to clear it on their own. So usually the assessment really will start after about 6 months of exposure. This evaluation is going to include measuring their liver function studies, assessing the severity of their liver disease and the possible need for treatment. The person doing this, the healthcare provider, the physician, the clinic, or whomever, will go through a series of blood tests. They will do a liver ultrasound to determine the status of the liver. They may proceed with a liver biopsy depending upon what they find. And they will then assess the needs of the patient. Now, one of the challenges we have right now is that the drugs that are made available are highly expensive. I said that earlier. That, in fact, the current criteria for instituting anti-HCV medicine, the criteria are very drastic. These folks have to be half dead. And I don't mean that in a funny way. I mean, these people have advanced liver disease and liver failure for them to qualify to get the antiviral therapy. So one of our challenges, I think, in this state and across the nation is going to be, how do we change that paradigm? How do we, in fact, now get these folks to be able to get therapy before they need a liver transplant, before they have transmitted the infection to multiple other individuals as well? Stay tuned. I think we're going to see motion on this. I think there's going to be a push to see the drug costs drop. the criteria for instituting antiviral therapy loosened a bit so that folks can get it earlier on. So that's why it's going to be important for us to identify where they're getting their care, who's giving their care, what kind of care are they getting, and give us that information. Concurrently, the provider is going to look and see, do they need other vaccinations? Do they need Hep A, Hep B? Those are preventable virus infections that we can prevent, because you don't want to add, insult to injury if they've already got active hepatitis C. And the other thing that has to be done is providing the counseling. And if you recall, I mentioned at the front end of this, keep them from passing the disease on to others. If they don't know they're infected, they're not going to pay any attention to prevention. But if they know they're infected, you can teach them how to not transmit the disease to those around them. These referral appointments should be tracked as much as you can possibly do, because I think we have, as I said earlier, much to learn from this as well. So what is required now? All acute HCV cases that first 6 months, pregnant women with HCV, infants born to mothers with HCV, children aged 5 years or less with HCV, and in October of 2016, the regulation will change and will require electronic laboratory reporting of all hepatitis reports, as you all are probably very quite aware. Pregnant women should be tested for anti-HCV only if they have HCV risk factors. I have a bias about that. I think they all ought to be tested, but that's my bias. It's like with HIV. Anybody that enters into the healthcare delivery system, from my estimation, should be tested at least once for HIV disease. Again, I would refer you to a guidance in the packet. Somewhere in there, Joy, is this stuff? Okay, good. Yes. And then you want to complete the reportable disease form and fax it to that particular number as well. Infants born to moms with HCV should be reported using this particular form, again, the fax number. HCV RNA tested while child visit at 2 to 4 months if that child was born to an HCV infected mom. HCV RNA testing should be repeated at a subsequent visit up to 6 months, independent of the initial HCV RNA, because that initial RNA of that infant may have been negative. So you need to check it up as far out as 6 months. And I tell you this because you could be getting calls from pediatricians and assorted others about how to test these children. An alternative anti-HCV antibody test can be offered no sooner than at age 18 months because the mom's got her antibody still floating around, and you have to be aware of that. You want to refer these children that are positive to identified HCV pediatric specialists in your region, and I will be perfectly honest, I'm not sure how many of them there are out there. That's going to be a challenge. I think you're going to find that most pediatricians, as they become educated about this, are going to be very helpful in helping us manage this particular problem. Again, the referral guidance, as you see there, and the reportable disease form and fax number once again. On this particular slide, and it's kind of busy, but I think this is a nice algorithm, if you will, for following what you're going to need to do in identifying individuals and so forth. And so under identifying individuals, I talked about this, individuals for testing. We talked about this earlier, baby boomers, high-risk factors, unregulated, I love this one, the scratches, the high-regulated, body piercing and or tattoos, household contact with a known HCV positive person. Why is that? It's got to do with sharing stuff, razors, that sort of thing in a household. Someone has their mic on. If they would be so kind as to mute, that would be super. Thank you. Household contact with a known HCV positive person. Remember, razors, toothbrushes, common elements that are shared. These people need to be tested as well. A history of the high-risk sexual behavior we've talked about, sexually transmitted infection history and the history of incarceration. When you do the testing, the pre-test counseling, you want to evaluate with these individuals the testing recommendations, kind of give them a sense of why it's important to be looking at this and doing this. It's also a potentially curable disease. You want to be able to intervene and do something at the right time. You want to assess them to see if they need concurrent HIV and Hep B testing. And you want to then also be sure that they stay in care as you're talking about these. So we've talked about option one, the local health departments, the antibody testing, what's going to happen with that, and the interpretation, the HCV RNA confirmatory and referral testing as well. Again, I'm going to talk about option two. Remember, this is only to be used for screening individuals, the rapid Hep C test, off-site when you're looking at groups of people such as Suboxone clinics, people you're testing and related to an exchange program of some sort, any outreach programs. We talked about earlier who should do this and how you need to be, the quality controls need to be done and that sort of thing. You're very familiar with that. This is, again, another slide which refers to the Kentucky testing recommendations for Hep C virus. This is the list. Memorize it. You're going to need it. It will become basic, I think, to your everyday work as you continue to evaluate these individuals. This is the risk assessment form, which is in your package as well. I think this has been pretty well explained to you. And then you have these algorithms that step you through what you should do. I will tell you a lot of, this looks fairly simple, but a lot of work went into preparing these algorithms. And I would suggest you take a copy and each one of these and stick it in front of you over your computer so that as you're looking and doing this work, you have this information available to you. The first is on antibody and HCV RNA quantitative specimen collection and handling guidance. Again, there is folks in the lab here in the room with me today that if you have questions about this, they can provide you that particular information. The next slide is screening and referral guidance. Here is a simple algorithm, the yes and no, assess for high-risk factors, no, no further action needed, yes, perform the test, and you see how that flows quite reasonably and makes very good sense. If I would caution you to look at the bottom, it's on my left, your right, light blue box. HCV RNA positive, that means the viral load is positive. Provide test results and counsel regarding the meaning of the test results and the ways to protect their liver. You need to be ready to talk to them about avoiding other things that are hepatotoxic, alcohol, other drugs, and you've got to be pretty forceful about it. Counsel regarding HCV transmission and ways to prevent spread. Assess for and recommend HIV and HPV testing, and I would urge you to do that. Assess for and consider vaccinating them with Hep A and B, and then getting them moving to the next step, which is to go to their primary care provider as a first step. And if they don't have one, and they're not insured, get them signed up, get them into Medicaid, get them a primary care provider, at least start the pathway to getting them into care. This is the outreach for such as a syringe exchange program. You can see the elements there. They're very familiar. You've got to have a confirmatory test if you're doing the rapid testing. A rapid test alone does not mean they have hepatitis C. They have to have a confirmatory test. That's an imperative. Again, you can see from that if they're positive, they're going to be tested then for the viral load, referred for testing for the viral load to confirm the positivity and the activity of the disease itself. Screening and referral for hepatitis among high-risk pregnant women, again, fairly clearly defined, very precise in what it says. The forms that are necessary are mentioned in that. Again, I would encourage you to walk through this yourself, just to familiarize yourself with that particular information. And then infants born to moms with hepatitis C, and again, the timing of that, when they should be tested, who should be doing the testing, where these children need to be taken care of, and the outreach that's going to be needed to the pediatric physician community in helping us manage this at will. You know, I talked about 900 pregnant moms. I'm not sure we know how many infected babies we've got out there right now, and that's one of our huge challenges. So we've got to pay attention to this. I think this is the tip of the iceberg, and that as we talk about prevention, as we talk about hepatitis C in the state of Kentucky, if we are not forward-thinking and aggressive in how we are doing this, I fear we're going to lose this. So if I sound a little bit excited about this, I am, because I think it is the right thing to do at the right time, and I encourage everyone to be engaged in this, because it's an imperative, I think, from the prevention and the public health standpoint. To help you with billing and codes, we have provided you a lot of information on this last slide here. Office visit for evaluation or management codes, the risk assessment code, the blood stick code, hepatitis C antibody, and the viral load quantification code, and then the consultation, initial or follow-up. There's taken some work to get this together in order for you to be able to do this. One of the things Dr. Humbaugh is always concerned about, as well as should be, is the sustainability of this program. We have monies now. We must sustain it so that you all can continue to do this as we continue to look for other funding sources to help with this. But I would urge you to consider using these codes as you see fit. So I'm going to stop there. I think I've allowed some time for questions, Joy.
Yes, ma'am.
You didn't have to flag me with a 5-minute
No, I did
sign.
not. I didn't have to get my sign out.
And I will confess, I may not know all the answers. I'm a infectious disease doctor. I come to this, I told Dr. Humbaugh this the other day, I didn't want to talk about hepatitis C. And the part of the challenge is that we couldn't talk about it. We didn't have anything to talk about. We knew it caused disease. We didn't know how bad it was. The drug treatments were terrible. The patients didn't like it. They didn't get any better. It was sort of an awful process. But you know, it's kind of like HIV. That has shifted. Now we have a way of identifying it better. We have the tools to evaluate who is at risk. We also have medicines that work. Now is the time to be proactive, get these people identified, get them into care, keep them in care, and let us abort this epidemic if we can here in the state of Kentucky. So I will stop there, Joy, and be glad to answer any questions. And I've got very smart people in the room that can help as well. So thank you very much.
Thank you, Dr. Hovind. Are there any questions from the field regarding Dr. Hovind's presentation, billing and coding, laboratory, specimen collection, storage and handling, centrifuges? We've got two representatives from the lab who can help us with those questions.
This is Amy at Bracken.
Yes, ma'am.
We're supposed to do the additional monitoring and reporting of the counseling and referral tracking. Do we need to come up with a spreadsheet for that, or will Frankfurt come up with that maybe as a front and back to the HCV3 form?
I think we could. I don't think there's any problem with us doing that. I have to get a hold of somebody that knows what you're talking about. So,
yes,
Just
Amy.
giving a spreadsheet.
Yeah, Amy. Yeah, we'll add that. We'll be glad to add that to the form number 3, and then certainly you'll want to document that in your progress notes and your nursing notes as the document.
She's looking for an Excel spreadsheet.
Oh, yeah.
A list. Is that what she's looking for?
Yeah. Dr. Humbaugh's asking if you're asking for an Excel spreadsheet. Is that what you are asking?
Yes. We could put it like on the back of the front of this form that has the information that they're requesting.
Sure. We'll do
And
that.
Okay, I also have another question.
Sure.
When we have to freeze the plasma on Fridays, do we leave it in the same tube, or do we need to draw the plasma out and put it in a different tube, or what do we need to do?
You need to leave it in the tube.
She says leave it in the tube,
Okay.
In that white top tube.
that preferred, whatever that thing is, the PPT. Yeah.
And then one other thing I do want to say about the PPT tubes, our current expiration date right now is February, the end of February, so be mindful, they're very expensive, and we will need to send some of those out, so we'll ask you to order, a smaller amount now, and then as we get a new lot in, then we can send more out. So you may just, in this first part, need to order them a couple of times.
Great, thank you. This is your chance to ask laboratory questions, because I can think from a mechanical standpoint, there may be some other questions. Does any other site have questions about the mechanics of the test of drawing the blood, and what do you do with the blood, and how you ship it?
This is Ann in Clark County.
Hi, Ann.
Good morning. You know I've always got several questions going.
I was waiting for you.
On the time frame between the antibody and the RNA testing, right now
Yes.
we currently have them come back in 2 weeks to get like their HIV testing. Is that going to be enough time to get that RNA test back if their antibody's positive?
What's the question here is, what's the turnaround time on the PCR on the antibody? Antibody to PCR, what's the turnaround report time to them?
I would say you would have it within 2 weeks, yes.
She says you'd have it within 2 weeks.
Okay. And then it's
Shorter turnaround time, but since you're saying 2 weeks, yes.
And Ann, certainly, if you don't receive those results within 2 weeks, please call the lab and follow up on the outcome, the results of that test, okay?
okay.
Yeah.
And then on the billing and coding end,
Yes.
I seen a sheet that had some prices. Is this going to be a slide? Is this going to be a sliding scale fee for this? Like we do $5 for HIV, $5 for syphilis. Is this going to be a $5 test, or is this going to be based on sliding scale, or?
So, I'll come up here.
Yeah.
So, first of all, for the clients who have private insurance, for those clients, you'll want to refer them to their medical home, and then their private insurance will be billed, okay? Secondly, for those clients that you will see in your local health department who have Medicaid, Dr. White met with the decision makers in Medicaid about adding codes and reimbursements to the preventive Medicaid schedule, and so effective January 1st, here in a couple of weeks, January 1st of 2016, CPT code 86803, which is the hepatitis C antibody test, will be effective in the preventive Medicaid service file and will be reimbursed in the amount of $19.42. For the quantification test, which includes the reverse transcription, that is CPT code 87522. The Medicaid reimbursement rate, again effective January 1st, will be $58.29. So those tests will be sent, both of those tests will be sent to DLS. Yeah, so both of those will be sent to DLS.
Remember, the one is going to be reflexed to the
Right,
other.
yeah.
Does
Okay.
that make sense, or should I say?
Yeah, why don't you mention
Yeah,
that,
yeah.
Dr. Humbaugh, if you
So,
don't mind.
just a reminder, this is Craig Humbaugh, a reminder that most of the, you're going to be sending a venipuncture, so that's blood. You're going to be sending it to Division of Laboratory Services for the screening test. If the screening test is positive, they'll make the decision. They'll automatically then send it for the confirmatory test that Dr. Hoven talked about that measures the actual virus. So you won't have to do any of that. But what Joy is saying is they'll reimburse you for the screening test, and then if the lab has to send it for a confirmatory test, then there's another code to be reimbursed for that. So the vast majority, if the screening tests are negative, they're not going to send it for a confirmatory test. They're just going to tell you that, you know, that patient had a negative screening test, and we're going to be able to relay that you're going to be able to relay that information to the patient. But if it's positive, they will automatically then send it for confirmation. You won't have to draw any additional blood or anything like that. They'll make that determination at the lab. And I assume then this information will be available on the outreach system just like it normally would for any tests that are sent to Division of Laboratories. So, sorry.
No, I'm glad you interjected there. So for the clients who do not have private insurance and those who do not have Medicaid, I do not know what the, I'm not certain on the fee collection component of those clients. So that's a deliverable that we will send out that we'll need to work on and check on, and then we'll get back with you all, okay? But hopefully the majority of the clients that you will screen will have Medicaid, or you will assist them enrolling through Connect to obtain Medicaid. But certainly there will be a subpopulation, a small population who will not be covered through Medicaid or private insurance, and so we'll need to get that information for you all to as to whether or not they'll slide or there will be a nominal fee.
So we'll try to figure that out, and just like you do now, I mean, you guys are the safety net, so I won't say that we will be able to cover all the costs, but remember, right now we're helping with the lab is helping with the kits, and we're sending those kits out, and so essentially you all are getting those per the program, so that should help with your cost. Does that make sense? Okay.
It does. As far as the cost, I'm not real concerned about. I just want to make sure that we're billing and coding it right. And it's like if we have to do that RNA, can you clarify, do we need to do a supplemental, or, because we've already PIF'd that patient, so would we add that to a supplemental, or I'm not sure how we would?
Yeah, let me follow up on that with Cynthia Robinson, and I'll send out a note to the nurse leaders to clarify that, okay? That's a great question.
Yeah.
Okay.
Thank you.
Sure.
And I've got one more.
Sure.
One more and I'm finished. Do we only put the positive RNAs on the HCV3 form, or do we put all the people that we test on that?
I think they're looking for the universe of clients who they're testing, so they can determine for the number of clients who are tested what the incidence will be of the patients that you all test within your agency.
That would be helpful.
Yeah.
Okay, thank you.
Yeah, you're welcome. What other questions from the field? You all are asking great questions. Yes.
This is Lisa from Northern Kentucky. How are you?
Hey, Lisa.
I have a comment about the coding and then a question.
Sure. Go right ahead.
For the rapid test, if we're doing any of that in syringe exchange or outreach,
Yes.
there's a modifier. It's an 803 with a modifier.
Okay.
So what is that
modifier? What is it?
Well, the manufacturer says it's QW.
Okay.
Which stands for CLIA waived.
Yeah.
But then I thought it might also be the 92, which is what we have on the rapid HIV.
Oh,
test.
okay.
So that's something Cynthia needs to check
So
out for.
Okay, sure.
But that would be one that we need to have the system, take as well.
Field testing.
Yes. Field testing. Yes. So I'll clarify that, Lisa. Thank you, and I'll get that from Cynthia, and I'll include that in our response with the other billing and coding questions. Thank you for pointing that out. And again, for those of y'all in the field who may have missed the first part of Lisa's question, that's only for the rapid HCV testing that would be completed in the field or through a HRSEP program, an outreach program in one's community. Okay, what was your question, Lisa?
My question about the specimens was, after we spin them, do they have to be frozen and shipped on ice, or are they refrigerated and then shipped on ice?
You can ship them, if you're gonna ship it immediately, you can, you don't have to freeze it, but you still wanna ship it on an ice pack, but if it's gonna be any delay, you need to freeze it and ship it on an ice pack.
And
Did
it's
everyone
helpful
hear
by-
that response? I'm sorry, Lisa, did you hear the response?
I did, but I was just gonna comment that,
Yeah,
two of
sure.
our counties don't have a lab freezer. So we'll have to purchase freezers, I guess.
Okay. So would that change the response in any way?
Well, then you would have to just refrigerate it for those people that don't have a freezer.
Yeah.
Freezer, I know we looked into that about a year or two ago, and we did find that some didn't have freezers, so, you know, just refrigerate it and send it.
You would
Okay.
prefer frozen though?
Yes.
But what's that gonna do to lab interpretation? It would be my question, if you don't freeze it.
It's still acceptable for refrigerated, but they prefer it frozen.
They prefer it frozen, but it's acceptable if it's refrigerated. So you do have an option, if you don't have a freezer.
Okay, thanks.
Thanks, Lisa. Who has the
Joy.
next question? Yes.
This is Amy Bracken again. Will this
Hey.
part of the ITV be training enough for our nurses, or will there be something on train put on so we can show
This-
documentation about that?
Sure. This training this presentation serves a dual role in that purpose, Amy, to serve as training for your nurses for the CCSG updates. Thank you. That's a great point. And so
This
to
is
that
Mary
end,
with Louisville.
hey, how you doing?
Good. We had a couple of questions in the room. I'll let our nursing director go.
Great.
Hey, Joy. It's Heather.
How you doing, Heather?
Doing good. So I want to make sure I'm clear on everything because,
Sure.
we've been doing the rapid test at our specialty clinic and our TB
Right.
clinic.
Right, and
So
that's still okay.
It's still okay to do the rapid.
Yes, ma'am.
Okay.
I'm gonna butt in here. We would prefer the venipuncture. Now, if you've already got in place rapid testing at designated sites and everybody's happy with it, I wouldn't necessarily rock the boat. I am convinced that any kind of testing is better than no testing. The preference here is for venipuncture testing, and it's got to do with the quality of the ability to interpret that rapid test itself. And so that we have some concerns about rapid testing. If you could, we would prefer venipuncture. That is the optimum way to get this done.
But if it's working well for them.
If it's working okay for you all, we're not going to rock the boat, just so you know our position on this.
Okay. So if we do venipuncture on somebody, we're going to send it to the state and take a copy of their insurance, or I guess what I'm asking is, what are we going to be charged as a health department to run that Hep C test?
Is Louisville Metro's lab going to be running the same test?
No, you're not
Not that
going to
I'm-
get a charge. It's going to come straight here to
Yeah.
DLS.
You're gonna send it to
Okay.
us,
Yeah.
you're gonna charge the patient for a confirmatory
Yeah.
test, because they're gonna already have the results of the rapid
Okay.
screening test.
So
Okay.
Heather, did you hear Dr. Humbaugh?
Yeah.
You send, okay, you send the results, you send the test specimens to DLS, and then the patient, once they had confirmatory results, the patient would be charged based on that. Did I say that correctly?
Patient will be charged for a
Yes.
confirmatory test.
Would be charged for the
Whether it's
confirmatory
positive
test.
or negative.
Yes, whether it's positive or negative.
This is Mary Steele. You all have been mentioning packets. Have those been sent out to the local health departments already, or?
Yeah, yes, I apologize for the confusion. The information that was sent out for the CCSG signature, that was sent out from the hepatitis C program all in one packet. And so that included the information for the CCSG, for the chapter on CCSG with the clinical guidelines. And then it also included the forms and the teaching sheets and the administrative reference guidance. So all four of those sections and chapters were included in one packet. But what you'll see in the CCSG is that information that will be posted in the appropriate chapters in the CCSG. So there will be actually a new hepatitis C chapter in the CCSG. The forms, Form 1, 2, and 3, that Dr. Hoven mentioned, will be in the forms section. The teaching sheets will be posted in the teaching sheet section. And the administrative reference guidance with the CPT codes and the billing information, that will be posted in the administrative reference. So that information was sent in one packet for the purposes of the CCSG, but as far as for the obtaining your all's medical director's signature. But just so you'll know that when the information is posted on the internet, all those sections have been split out and they'll be posted, and hyperlinks will be available for y'all to print and review that information separately.
So do we know when the CCSG will be updated on the website with this new edition?
I'm working on that right now as hard and fast as I can.
Okay, thank you.
Yeah, sure. Sure.
Hey, Joy, this is Julia.
Oh, sure. Sure. Who was next? Madison? Or was that still Louisville Metro? Did y'all have other questions?
This is Ava, but if someone else was ahead of me, that's fine.
Hi, Ava. Go right ahead.
My question was regarding Medicaid patients.
Sure.
Is it acceptable to refer them to their primary care provider versus offering the testing at the health department, or do you feel like we need to offer that to those patients?
Yes, but no, yeah, but certainly that's fine. But also remember, Ava, that HCV testing is recommended as a part of the family planning visit, and it's a part of the integrated visit. So if that client's already there, for example, for family planning, it may be that they meet the risk factor criteria for doing HCV testing while they're there for family planning. So in those types of situations, you would certainly see that client for family planning provide that HCV testing while they're there, and then bill Medicaid for that service. Okay.
Yeah, it does. And along with that, we also bill private insurance when we do family planning. So in that case, we would go ahead and refer them to their doctor for the testing, even though it's part of their family planning visit.
Yes. And well, would you bill that person's private insurance?
Yes, ma'am. We've started doing that in July.
Yeah, but I mean for HCV testing. That would be a part of, that would be a part of what
I guess that would be okay. It would be okay, but it just said in the paperwork that if they had insurance to send them to their provider, so I just wanted to.
Sure. That distinction, I think, would be made if someone comes in solely for HCV testing. But certainly if their client is already there, then what and you have the ability to bill that client's insurance company, and they're there for another reason, they presented for another type of visit, and you can bill their insurance company for both their family planning and their HCV testing, please go ahead and do that.
Yeah, let me jump in on this.
Yeah.
And I think one of the things we're going to need feedback on those individuals whom you refer to their primary care provider or their physician, if they've got insurance, if you learn or find out that they're not getting their Hep C testing, that in fact the doctor's office or the clinic is not providing that testing as they have requested, we need to know about this, because I think then we would start articulating a different mechanism of doing this. So that would be important for us to know.
Does that help, Ava?
Yes, ma'am. Thank you.
You're welcome. Who has the next question?
Hey, Joy, this is Julia at Barren River.
Hey, Julia.
Quick question regarding the packaging and shipping.
Yes.
Do I understand it correctly that all specimens are going to be sent to the lab on ice packs then?
Yes, you're exactly correct. Yes, ma'am.
Okay, so then our concern in the room is postage. I wonder how much that's going to cost.
Okay. I'm looking at the lab coat.
We don't normally cover postage, so we can talk to someone here that can help us with that.
Okay. Thanks for bringing that up, and so they'll talk about the postage piece, and I'll be sure to let you all know. I'll add that to my list. I know that the lab doesn't normally cover postage, so with that being said, they'll review that and talk about that, and I'll let you know what the final outcome is of that conversation.
Great, thanks, Joy.
Sure.
Joey,
Yes.
this is Paula in Estill County.
Hey,
I'm sorry.
Paula.
Hello, how are you?
Good.
I'm sorry, I'm probably being redundant, but we
No,
are a
no.
little bit confused. At first we heard if they had private insurance or Medicaid, refer them to their primary for
Right.
testing.
Right.
And then we got the codes, the CPT codes for Medicaid reimbursement.
Right.
So are you saying that we can do testing in the clinic if they have Medicaid?
Yes, ma'am. Yes, you're exactly right, Paula. That was the impetus to go to Medicaid and say, will you cover these screening codes to encourage local health departments and our other partners to go ahead and provide that screening and that testing and be able to turn around and bill Medicaid. So absolutely, if a client presents for HCV testing, whether it's solely for that's the only reason they're presenting for services, or if they're presenting for another service, and that's a part of that integrated service that you'll be providing for that client that day, please use the same screening criteria to provide the HCV screening test. Whether or not they're just for HCV testing or family planning or whatever. And then you'll be able to bill Medicaid effective January 1st for reimbursement.
Okay, thank you. One other question.
Sure.
Yes. One other question. Now, I know you said we do these with family planning visits. We do them with STD visits.
Yes.
If they come in for HIV testing, we know all that. What about our WIC clients? Should we be encouraging this maybe to our WIC clients, asking new moms or just pregnant moms if they've ever been tested? Should we be, maybe screening them with questions to see if they even need testing?
Yes, absolutely. And so what we'll need to do is make sure that response we just gave you is crosswalked with the WIC chapter and make sure that the WIC chapter is reflective of that same guidance and that same recommendation. So absolutely.
Okay. Will we be able to, well, I think we would, but we would be able to do their testing or whatever while they're there, or would that need to be a separate visit?
No, I would go ahead and screen those women, or screen the WIC clients while they're there in your facility. I wouldn't miss that opportunity.
Right. What about the infants? Say if you've got a mom in that, maybe has a new baby that maybe didn't get tested, because we all know they all tell the truth, but maybe they didn't get tested. We don't test those infants though. We would refer them. Right.
Yes.
Okay.
You're exactly right. And when we had the conversations with the Nurse Executive Committee about infant testing, there was general consensus in the room, and I am aware of this through previous conversations with nurses over the last many years, that nurses do not have they're not equipped with the skill sets nor the competencies to do infant serum testing, so we certainly don't want to ask of you all skills that you don't feel comfortable doing or are not competent or skilled to do. So certainly those types of infant testing and screenings should be referred to your local pediatrician or a provider in your community who would be able to provide those screening services for infants. Does that help?
Yes. Thank you so much. And you and everyone out there have a Merry Christmas.
Thank you. All right, who's next?
Joy, this is Amy at Bracken again.
Yes, Amy.
Is KDPH going to come up with any outreach posters or pamphlets or anything that we might be able to use out in the public to inform of the services that's now available?
Great question. Let me pose that to Kathy, and that's a wonderful idea. And I know that there's a lot of information on the hepatitis C CDC website, and so for patient education materials, but as far as posters or whatever, I'll ask her to research that and be sure to disseminate, if there is anything available, be sure to disseminate that to you all so you can promote the screenings within your agency and your community. Great idea. Great idea. Who else has a question? Okay. Well, and kind of, Amy, you've given us the perfect segue. Our next presenter, and before I introduce Jennifer, if you have other questions, and certainly as implementation of this program progresses, other questions, may pop up, and I'll be sure to work with Dr. Brawley and Kathy and Dr. Hoven to respond to the questions that you all had about billing and coding and nursing documentation and outreach. So we'll be sure to get all those responses to you. Remember, the implementation date for the CCSG emergency revisions is January 15th. So we wanted to make sure that, because there's 2 weeks in there with the holidays, I wasn't sure how long, if you would be able to chase down your medical director to sign your protocols or not, and you all might be on vacation. So we extended that day just a little bit till January 15th. Remember that the Medicaid reimbursement piece will be in place for hepatitis C on January 1st. So you should have plenty of time, once you get your medical director to sign your protocols, to complete your staff training, to get the Medicaid reimbursements in place to be able to roll out your programs by January 15th. Okay? And so Jennifer Hunter, who is the nurse leader at the Northern Kentucky Health Department, was one of the pilot sites for the hepatitis C pilot program for testing and screening. And so she's with us today remotely through her health department, and she's going to be providing some best practices and some outcomes of her pilot program. And we thought that this would be an opportunity for another local health department, one of your all's colleagues and peers, to share what their experiences were with hepatitis C screening. And so maybe you might be able to steal some of her ideas and incorporate them in your local health department. So Jennifer, before I turn the mic over to you, I wanted to thank Dr. Artis Hoven again for your excellent presentation. Thank you. Thank you so much, and we appreciate your expertise, and we'll get together on those billing and coding questions, okay? All right. So Jennifer, are you, I see you there, are you all ready to go?
I am.
Okay. All right. Well, I will sit down and turn the mic over to you. Thank you, Jennifer, for joining us today.
Thank you. And I just want to make sure, can everyone see our PowerPoint?
Yes.
No in Lexington.
No in Bracken.
No in Bullitt.
No in Estill.
No in Bowling Green. Okay. We're going to work on it here, guys.
Hold on a second. Jennifer, if you could go on with your presentation, I'll get in touch with COT, okay?
Okay. I want to make sure that I also mention my partner in crime, Joyce Rice, who's the epidemiology manager here at the Northern Kentucky Health Department, was involved in this with me, and she cannot be here today, but I wanted to make sure that I gave her a shout out for helping. Public health, just for a little bit of background about myself. I'm in my 26th year of being a registered nurse here in Northern Kentucky for public health. And along the time that I've been here, there has been many trends that have changed. They changed with economic times. They've changed with world times, things that are going on in the world. And some things that were evident when I first started 26 years ago are kind of coming full circle. And one of those things is that public health nursing is trending more toward the community. We still have our clinical role within the four walls of our clinics in providing those services, but I see it moving more toward out in the community, which this actual testing pilot that I'm going to talk on is an example of that. Also, there are more complex issues in public health than there used to be. When I first started, things seemed to be a little bit simpler. And when you found something, you diagnosed something, you followed treatment guidelines, and it was through. But now, things are a little bit more, whether it's economic, mental health issues become involved. There are more complex issues that we are having to deal with. And definitely, the landscape along not only northern Kentucky, but Kentucky and the nation is changing. Some background of our agency. We were nationally accredited on February 28, 2013. We were one of the first 11 health departments nationwide to be nationally accredited by the Public Health Accreditation Board. And probably the things on this slide everyone knows about in regards to, what accreditation means for your health department and for ours. And looking at this project came around the same time we were involved with our journey for accreditation. And we felt that this project was a good example of one of the domains that you have to be responsible for when you're providing excellent public health services. So I just wanted to give a mention of that. A little bit of background for those of you who aren't aware of Northern Kentucky. On the slide, there's a map. We are the four most northern counties. We cover Boone, Kenton, Campbell, and Grant. And there's a little over 400,000 people who reside in our four-county district. And we sit right across from Cincinnati and the Ohio River, as you can see, that goes up and above those counties. It separates us from the other counties to the north. Our demographics, we have a wide variety. We have urban, suburban, and rural. Our actual race breakdown, predominantly white, non-Hispanic. Only about 3% African American, and rapidly increasing is our Hispanic population. Right now we're at around 2.7% for all four counties. Our poverty range runs from about 9.2 to 18.4. It depends upon where in northern Kentucky. We have pockets of poverty that's considered to be severe, and then obviously some of our counties have very affluent populations in them. We have a number of large cities, Covington, Newport, and Florence. In our Grant County, it's a more rural county, and that's toward our south. As reported in the presentation before me, obviously hepatitis C, that's a reportable disease in Kentucky, the most rapidly bloodborne infection in the United States. And something that we started to look at here in northern Kentucky was around 2010 to 2011. All of a sudden, we started to see a rapid increase in the hepatitis C that was coming into our agency from the outside. For hepatitis C, just like was mentioned before, the high-risk behaviors to getting hepatitis C, intravenous drug using, persons with certain medical conditions that have blood transfusions, clotting factors, sexual relations with people with hepatitis C. In looking at our case rate, which we started to really pay attention to, like I said, around 2010, 2011, we were at 10.3, and this was for hepatitis C. In 2013, which was in the middle of our hepatitis C screening project, we had jumped up to 13 per 100,000. If you look at the comparison, Kentucky at that time was only 3.2, and the United States was 0.3 or 0.4. So we could see when we were looking at this data that something was definitely going on in northern Kentucky. As you can see, we started to graph all the way back in 2007. The 2009, there was a little reporting incident that happened in that year, the graph doesn't look correct. But as you can see, these were acute hepatitis C cases that started to come into us. In 2010 was when we started to see the big jump. And as you can see all along, it went up very rapidly. In 2014, that's when our pilot stopped. So we are suspecting that because we did a number of the testings in our area, that's one of the reasons that graph is lower. Along with our acute was our non-acute hepatitis C. So going back to 2006, we saw the same pattern. So it's both of the acute and non-acute obviously were going up. So we also looked at our acute hepatitis B cases. That was on the rise too. It started around the same year, which is 2010. And if you look at that all the way up to 2014, we were still seeing an increase. The non-acute hepatitis B, the graph's a little bit different, but you still saw the increase from 2012, 2013, and 2014. So why was Northern Kentucky a hot spot for this? In looking at the different demographics, the cultural things that were going on in Northern Kentucky, we were a very vulnerable population. Because the Kentucky laws had a crackdown on the pill mills, we had a number of addicted populations in Northern Kentucky that all of a sudden didn't have the pills that they used to take, the opiates, to get their high. And so we were kind of vulnerable. And heroin came in and infused our area and just replaced the opiates for the addiction. Instead of the pills, people were actually using and shooting up heroin. At that time, when we were looking at doing this pilot, Kentucky law prohibited needle exchange programs. Luckily, since then, that has changed. But at the time we were doing this pilot, we were not allowed to even have or consider a needle exchange program. So in 2012, I was approached by the Kentucky Department for Public Health in regards to starting a testing pilot in our area. The CDC was also interested in knowing about Northern Kentucky, Kentucky in general, but really in looking at and delving down into the actual what was going on. You know, what we thought was hepatitis C, that was probably just the tip of the iceberg, and so they really wanted to infuse money into our area to help us get these testings done. The testing is very expensive, so it's not something that we could have provided on site without the help of CDC and the state. So when we started first talking about the project, CDC mentioned that they would fund it on a month-to-month basis. And the reason that they did that is they were looking at our data and our data log that we had to see and look at, you know, what were the results that we're showing? Was the results that they thought it would be? Is there any other problems going on that are causing hepatitis C to go up? But basically, it was just the month-to-month, not just a blanket 12-month pilot. So what we decided to do, because hepatitis C was not something that was normally provided in local health departments, even though our registered nurses and other staff know about hepatitis C, we still had to start with staff education. Because before that you can educate a person or the public, we had to make sure that our nurses knew exactly what hepatitis disease was, you know, what, from the whole beginning, kind of like a hepatitis C 101. And then looking at, you know, the high-risk factors, how it can be communicable, how do you counsel someone if they have a positive result, and what information was the best information for them to use, to give to people. We also had to train the RNs on specimen collection and shipping processes, because again, this wasn't something that we normally provided. Again, with that came the coding information for the PEF, and all of the little details that the nurses like to know about things, just to make sure that the process runs smoothly. And then we were asked, what kind of hepatitis C log and what kind of data would you like to collect on that? And that's where Joyce Rice really came into play, looking at specific high-risk factors that we wanted to assess in our population. Once we did that, we put into a log, kind of like a draft, and then the nurses had to be trained on that log also. You probably can't see all the specifics of the log, but this was the first log that was used as an actual patient information. And the nurses kept this log at their desk. So whenever they tested someone, at the top we did a pseudo number, which was the date of the test and the client initials. We found out what their birthday was. On the confirmatory test result, obviously, we had that in there. So we had the actual test result and then the confirmatory, their gender, race, ethnicity. We also wanted to look at zip code, so we could GIS map it and look at our 4 counties and see where the hot spots were. We wanted to know their age, and then delve down into actual behaviors. Was there history of IV drug use? Was there a history of multiple sex partners? Was it men having sex with men? Was there a recent exposure to someone that was known hepatitis C positive? HIV test results with this, we combined them both. The county that they originated in, if they had a previous STD, any tattoos, and the last column on there was for the nurse to put her initials. Once we got our staff trained, we got the log to what we wanted it to be. We picked out the information that we wanted to hand out. We decided that we had to outreach to the community, because how can people know to come in for testing if they don't know that we're going to offer it? So what we started to do was both internal and external outreach. The actual hepatitis C pamphlets were given to clients who would come into our services, so that we'd be giving a consistent message that yes, we have this to offer, you're welcome to get this testing done if you would like it. We also had posters and information in our clinic lobbies and in all the exam rooms. We made calls to the community providers so that they could refer clients into us, and most of those community providers were ones that we had worked with before, on other community issues. And then we also did media releases. We did community columns. We used social media such as Facebook, Twitter, our health department website. We sent out a special mailing to all of our Board of Health members, not only on our district Board of Health, but the 4 local boards also, so that they could know that we were offering this test. And then also we communicated with our local hospital system. Something in the process that we decided, we wanted to make this service as easy as possible. And so at the time, we decided to do open access scheduling. And what that meant was that we could provide this service Monday through Friday, anytime between 8 and 5. We would take walk-ins if they didn't have an appointment. And also, you could get the service as a standalone or in conjunction with any other services we were offering. At that time, our agency decided that it was going to be a no cost. So we were removing the barrier of cost, and this created easier access for those that weren't insured. And remember, the Affordable Care Act was not instituted at this time, so those that did not have insurance, there really wasn't the Connect system that there is now for them to help them get coverage for that. So basically, that's why we decided to just make it a no cost. We also decided to make it an opt-out policy. And what that means is that it was a package deal. When you were coming in to get a hepatitis C test, you also got an HIV and a VDRL. Unless the client opted out of one of these tests, the whole package would be done on everyone. Also in the process, like I said before, we talked to external agencies, and our federally qualified healthcare center, which is Health Point in our area, St. Elizabeth Healthcare. In Northern Kentucky, we do have a methadone clinic in Covington, so we also offered for them to come in for testing. All of the drug rehab facilities, our Safety Net Alliance, we have a cold shelter in Northern Kentucky along with the homeless clinic, and we also did advertising at our Turfway racetrack. And that was in conjunction with our local college, which is Northern Kentucky University, the College of Health Professions. So they also helped us, to spread the word. We worked with other divisions within our own agency to make sure that everyone is aware of what we were going to offer, and that they could also themselves refer people in to receive this testing. And basically, the internal and external events that were provided were coordinated by all of our division. So it was really a whole agency pilot project, not just a clinical services. It was also a team effort. The nurses, clerks, health educators, epidemiology, we had teams of people that would go off-site to talk about this. Actually go off and talk to high risk, for example, at the drug rehab facilities. We'd actually go and say, okay, we have this to offer. This is why you should get it done, that kind of thing. And then to know that there was no charge, we can also help you. For example, we had an actual facility that brought a bus and bussed in a number of people to our health center who actually wanted to get the testing done. And so we wanted to try to take away every barrier that we could in order to get this testing pilot completed. And talking to the nurses about post-counseling, and actually the results counseling, we found a major gap in Northern Kentucky. We did not have one practice or physician that would take someone with a positive result and treat them if they did not have insurance. So the uninsured group in Northern Kentucky was at a huge loss, and this was a big barrier. And so we contacted the University of Kentucky and University of Louisville, and they agreed to take our referrals, but the problem with that was the transportation. People in our area, that's an hour and a half drive just to get to UK or U of L. And even though we were very appreciative for them saying that they would take positive test results and counsel and diagnose them, it really wasn't a real option for our clients. So our actual testing pilot was May 21st of 2012 to October 31st of 2014. We screened 2,704 people. 375 people were positive, and that was 13.8% of our population that we screened on the initial testing. 352 had confirmatory testing, and 86% of those were positive, 13.3 were negative. One thing that did happen that was a little bit of a bump in the road through our pilot was CDC changed the screening layer requirements on it. So there was a little bit of change in that, and the actual follow-up that we had to do with the people that we wanted to get back in to get retested, those people were lost to follow-up. So we did have a little bit of break in our system and didn't provide the screening until everything got worked out. Our results, when we looked at the difference between males and females, 56% were female who came in to be tested, 43% were male. The race, 84% were white, 15% were African American, and our positives, 96% were white. And the majority of what we were seeing was they weren't born between 1945 and 65, like the research showed. And so as we went on month by month looking at our data log and giving that to Kathy Sanders at State and then also to CDC, we started to see that there was a trend. The people who we were seeing were younger, and they were not in that category that normally you see that the baby boomers would normally be positive. This graph is our 4 counties, and you can see the actual people who were tested is the blue column. Those that were in the red, those are the ones that were positive. Some of the data on this is a little bit misleading because some of the counties actually have rehabilitation centers, and they were the ones that bussed in a large number of people. And so when you look at, for say, like Campbell County, they were the ones that had the people that were being bussed in. So it looks like they have screened many more people than the other counties, which if you look at it all, actually those that were most positive were those in Boone County. And I'll talk a little bit about some zip codes that we looked at also. On this slide, it actually goes by zip code. We wanted to look at that, so like I said, so we could GIS map it and look to see where the hot spots were. And when we actually looked at the zip codes, there were a number of hot spots. And then what we did was investigate more down into that to see what populations were living in those zip codes. Here's the GIS map that shows the actual results. One thing that we pretty much knew this, but it's nice to look at it in color on a map. All 4 counties had pervasive hepatitis C positives. Even though some parts of the counties are darker green, which got also into the orange, into the red, which is more up toward the northernmost tip, right by the Ohio River across from Cincinnati, those were our hot spots in those areas. So even though those were more urban and that were down into the cities, if you look all the way down to the south of Grant County, there was hepatitis C all over our district. We also graphed it, which wasn't too much of a pretty sight either. Northern Kentucky is the red line, and so you can see what our hepatitis C rate was at the time. The state is the middle green line, and the nation is the bottom line. So even if you didn't know anything about public health, nor you were an epidemiologist or a nurse learning how to read these, it definitely painted the picture that Northern Kentucky was a huge area for hepatitis C compared to the state and even to the nation. Not something that we're really proud of, but we definitely put ourselves on the map. The age group, this is what I talked about before, and looking at thinking that people were going to be more in the 50, 55, 60 age category. If you looked at our results, those that were positive, the highest population was between 20 and 25. So when you have that person that's that young coming in, obviously they're doing something that's a high risk factor to put them at risk. But even if you looked at it, our 15-year-old to 20-year-old, we did have positives in that age category, which really concerned us. So the majority of our positives were from 15 to 30. Some of the risk factors, obviously, the history of IV drug use was our #1 risk factor. Multiple sex partners and tattoos were our second and third highest risk factor. Look at the column that says born between 45 and 65. That was our second smallest risk factor, next to men having sex with men. So we knew this was really, in Northern Kentucky at least, this was really a younger person's disease. Then we also looked at, does it mean if you have more than one risk factor, does that increase your chance in Northern Kentucky for hepatitis C? The actual green column, those are the ones that were tested. So if you look at that compared to the blue column, which are reactive, if you had one risk factor, it didn't really give you a big increase until you got to 2 risk factors. That was the tipping point. When you got to the 2 risk factors in your own personal history, that was more likely for you to have a hepatitis C positive result. Our pilot ended on October 31st of 2014. The funding was not renewed by CDC. And I tried to look at, with our district director of health, on could we sustain this program by ourselves. And with the number of people we were testing on a monthly basis, it was going to cost our agency over $200,000 a year just to continue our project. And really that was cost prohibitive. We didn't have that kind of money to continue with that. Even though we knew it was a major problem, that just wasn't an option for us. And so some of the things that we tried to do, we tried to apply for an NIH grant, there was a CDC grant, and there were some local grants, but none of those came up with any funding. So what we decided to do was, let's go out and tell our story. Maybe that's where we can find somebody who will help us fund this, because it was a serious problem in our area. We knew that heroin had a big impact on our hepatitis C rates. Also, the overdose deaths in our area were going up, and so we needed to do something. We couldn't just stop. So Joyce and I presented a poster project at the Kentucky Hepatitis, the Silent Epidemic in Kentucky, the annual conference. We did that. We also presented at the Kentucky Public Health Association, the annual conference. We were also asked to go to Washington, D.C. and talk about Northern Kentucky's specific project, the National Alliance of State and Territorial AIDS Directors. We thought for sure we could shake some money trees in Washington, D.C., but that was not the case. And then we also presented at Kentucky's HIV annual conference. We did a media campaign. Our entire report, we did a presentation for our district board of health. We put it on our website. We used social media. We actually did interviews with our local news stations from Cincinnati and Northern Kentucky. And then we also, in a couple of different areas, we applied for publication of our pilot project. Currently, this week, as a matter of fact, we provided another outreach project, which was the Rapid Hepatitis C Outreach Project at the local methadone clinic that we had. The Rapid HCV training was specific for our nurses, and like the PowerPoint before mine, you have to have specific training for the Rapid. And in our program and our model of staffing that we have here in Northern Kentucky, we use RNs for this purpose. There's a number of medical issues that come up that we feel comfortable with the RNs talking about, and so that's why we use that staffing model. We use the protocols for the licensed professionals. Again, those are clinical protocols. We used that and basically took those to the offsite location. And we performed the rapid hepatitis C along with the oral HIV screening, and we are doing that on site. If it is positive, we're drawing a venous sample to get the confirmatory. And if it's positive, we're drawing the venous sample for HIV, hepatitis C, and syphilis. The nurses are doing counseling on site for the screening results, and then obviously for those that have to be confirmed, we'll go back, in a few weeks to the methadone clinic to counsel anybody on their positive results. And just for, a preliminary, the first day that we went, which was Monday, we did 7 rapid hepatitis C screenings, and all 7 were positive. So we're really curious about what the rest of the week will show. Today is the last day that we're going to be there, but we're excited about those results and seeing what we can do. Our conclusions, definitely our pilot project, we're very appreciative. Kathy Sanders was wonderful to work with. Dr. Brawley helped us also, and it gave us an idea to really what was going on in Northern Kentucky, what were the high-risk factors, and obviously we found out that the IV drug use with the heroin problem in Northern Kentucky, was one of the major factors for our hepatitis C rates to go up. And we actually got to see those high-risk populations in that GIS map. That data can help us in providing some other strategies to help those populations. We also increased our partnerships, not only internally between our entire agency, the majority clinical services, epidemiology, and community health, but our external. We really got to work with the other healthcare agencies within our community, and we were the only one in the community that was actually doing this. So the community in general was kind of cheering us on because they wanted to know what the results were also. We were able to define who our population was. Obviously, we do need to outreach more to the baby boomer population, but in looking at our data, our actual data showed that it was a younger population that we need to reach out to. And also, in general, we were able to bring access and education of hepatitis C for our entire population. We were able to do that, even if we weren't able to continue the testing at the time. And in general, our community really now knows that we do have a problem. Our major gap, fortunately, the Affordable Care Act was then enacted, and we do have connectors on site. So when we institute the new guidelines from the core clinical services guidelines, we will have another access point for people when they come in. If they don't have insurance and they're positive, we can get them hooked up with our connector to help get them coverage. Our next steps, continue our efforts for funding, grants, collaborations with community partners. We will definitely initiate the hepatitis C screening guidelines that were just put out in the core clinical services guide, and continue to educate those at high risk that they definitely need to be screened. The contact information is on here. My contact information and Joyce's. If anyone has any questions or concerns about instituting, the new guidelines, we would be glad to help you with those. Thank you.
To Northern Kentucky, one, for your commitment and interest and dedication to providing a hepatitis C pilot screening program in your local health department district, and then secondly, for sharing the results and the outcomes of that pilot program. May I ask you if you'd be willing to share your PowerPoint presentation with me so I can share that, send that out to the field?
Yeah, I sent that to you 2 days ago.
Haven't gotten anything. So would you mind to resend that to me, and I'll be glad
Sure.
to share that with the state.
Yes,
Thank
I
you
can.
all right, thank you so much. I won't keep you because I know you've got another obligation, but does anybody have any quick questions for Jennifer? Yeah, Dr. Hoban?
Jennifer, this is Artis Hoban, and thank you very much. I'm curious, as a physician, I'm curious as to what you see as the challenges. I mean, I know what the challenge is, but do you have any concept about the pathway to get these folks into care? Obviously, you talked about referrals to UK and the University of Louisville, but distance was an issue in getting them there was the challenge. As you've thought about this and you've engaged with the physician community in your neck of the woods, how do you see us moving ahead? How do you see us, in fact, trying to get rid of that barrier? Obviously, if they don't have insurance, we understand it, but there has to be another way for us to, in fact, improve access to care. Have you given this some thought, and what would you recommend we at least do as a next step?
We have, because that was one of our major concerns. Because who wants to test this big population, and you have over 300 people that are positive, and you say, well, I'm sorry, there's nothing we can do for you. What we did at first was we contacted Cincinnati, because the University of Cincinnati has an actual hepatitis C clinic there. At the time, at first, they said they would take our clients. But then they started seeing so many that they said, no, we're not taking anybody from Kentucky who's positive. So what we did next was we had some board members that were actually physicians in looking at this, and with our hospital that we have one hospital, St. Elizabeth Healthcare in our area. There's ongoing talk about possibly having some kind of hepatitis C clinic in our local area, but there's not many people that want to bite just because of the cost of it. With Connect, though, we are able to put people on, and we're thinking that's going to be the bridge for us. That's why we tried really hard to get the Connect grant so we could have someone on site, and that's kind of what our next process is looking for. Is we have the referral sources. We have physicians who said, absolutely, if somebody has health insurance, we will take them. But it's just those that fall between the cracks that don't. But hopefully, those kind of people, we can get them into our center and have them apply for health coverage and then refer them right away. But it's not an easy problem to solve at all.
Thank you.
Any other questions for Jennifer before she needs to scoot? She's got another obligation this morning. Thank you again, Jennifer.
Okay, and I'll send that PowerPoint again.
Okay, thank you for resending it. Sorry I didn't get it. All right. So next we have the Pennyroyal District Health Department. They're going to be broadcasting from the Crittenden County Health Department. And I invited, and I'll let Benita come up and share with you all how this came to be. We received an outstanding quality assurance site visit review from Gina Reed, and who is the Division of Women's Health QA coordinator in the western part of the state. And Pennyroyal has such an outstanding review that we felt like we wanted to share that with the state and some of their initiatives that they have implemented within their district that have had a positive outcome for delivering family planning services in their district. So with that being said, I'll turn the camera over to Benita Decker, who is the Department for Public Health Family Planning Program Director, and I'll let you introduce Pennyroyal.
Okay.
Thank you, Benita.
Thank you, Joy. As Joy said, on a site visit, Gina found that Pennyroyal was doing great things with family planning services, and in a day when we don't hear that very often, that is incredibly encouraging, and we wanted to share that with all of our partners across the state to show you that family planning can work. And so we're going to have with us this morning from Pennyroyal, and we thank them for coming and presenting for us. Allison Bashir, the director, Angie Jooms, the nurse leader, Diana Rogers, a financial person, and Kim Jackson, their APRN. And I'm looking forward to, I won't tell you what they found because I want them to be able to share that with you. And but we're excited, ladies, for you being here, and we look forward to your presentation today.
And you'll need to advance your slides.
Okay, I will. No, I will.
Okay, all right. Thank you.
All right, this is Allison Bashir, the director for Penny Rowell District. And if you would go ahead and advance to the next slide. Just want to thank you for having us speak today. We've just tried to, over the past year, just try some new things, expand services, streamline some processes, just to create more efficiency and consistency throughout our district. So beginning in January, we implemented some new things with our family planning. We have a physician on staff here, Dr. Gavin, who travels around, and he's been doing some family planning in one county, and we decided to kind of expand that to the other 4 and team up with our nurse practitioner. So started all this process by doing some male exams, and we've added some sports physicals, as well as doing the next one on. And I'll let Kim talk more about that. She's trained to do that, and mainly our physician does the sports physicals and male exams, as well as family planning. We also started to take some private insurance and started slow looking at what's the most popular in our area and tried to get a few of those on board and grow as we can. And so that's helped to bring in more revenue, and Dana will be talking specifically about some of that later on. Also, we wanted to do some advertising and really put our face out there because, you know, I think probably everyone can relate. There's still that stigma with the health department. People quite don't know what we do, and they think we just serve a certain group of people. And so we just really need to educate, you know, our community partners and the people that live there of what we can offer and what service we can provide to them. So by being able to take some private insurance, it helps open the door to broaden our clientele. And if you'll go ahead, I'll talk real quick just about some policies. We updated our policies. Some of these were not new. We kind of had a little bit of hodgepodge, and since everyone's kind of working on accreditation, we're really taking a look at our internal controls and our policies and trying to make sure they're updated, that everyone's trained and everything's consistent. And so some of these were protocols, some of these were clinical procedures, some of these were policies, and we just wanted to get everything in the same format and to get it in a way that we're annually reviewing it. We found that we might create something and, you know, it sits on the shelf and we haven't looked at it in 5 years and it's way out of date. So by putting it as a policy, present it to our Board of Health, they review it, they approve, sign off, I sign off, our medical director signs off as needed. It puts it in a way that we're going to look at it every year and make sure it's current and up to date. So, and I'm happy to share any of those with you. I can send those to Joy and she can send those out if you want to see specifically what we've implemented in our family planning program. But you're seeing a slide right now. This was our advertising, and we've tweaked it since then, but we just wanted to put our face out there. These are our providers, and this is what we can do for you. We listed all of our health centers and their numbers, and then at the bottom we've listed some insurances that we can take, and that has helped to bring in more private, private insurance and help to expand services. So. That's pretty much all I have. I'm going to turn it over, and people can ask questions later on, but hopefully we've got some good information for you today. So I'm going to turn it over to Kim, our nurse practitioner.
Good morning. I started doing the Nexplanons in June of 2014. We just had a nurse practitioner update in October at Bardstown, we have that every year, and I know we had the opportunity for some of the practitioners who have not been trained to sign up for that, and I hope several of them took advantage of it. As you can see from the slide, we've done about 50 to date. We serve 5 counties, and some of the counties it's just been a couple, and some of them it's been up to 20. It just depends on, sometimes they're very interested, and sometimes not so much. I seem to have a bigger interest for that as far as a long-acting contraception than I do the IUD right now. So I don't know if it's because it's the latest and greatest. They're hearing more about it. The biggest non-compliance reason that they want it removed is the breakthrough bleeding. That is, it is a side effect. I think, again, it's the importance of counseling, letting them know that can be a chronic, ongoing problem. But again, it's long-acting. That is a 3-year birth control. And for some of our patients, different problems, just remembering to take a method that they have to think about every day or every week or even once a month or every 3 months, that 3-year thing really works for them. Of course, we do, stress the importance of that yearly exam regardless of, whether you're in for birth control or not. But most people, it's pretty simple procedure. I've not had any, I'm going to not stress myself, so far so good, like I said, but we've just had a few. The only reason I've had to remove them so far was for the irregular bleeding. I've had several people that came to me to have a Implanon removed, which was the device that was started before the Nexplanon. And, it's just time for it to come out. And I've had a couple of women request the Nexplanon after having that out. So it seems so far to be an effective form of birth control. I personally like it so much better than the Norplant of the old days. So I'm pretty excited to offer this to our patients, and hope we'll get a good turnout with it. That's about all I got. Thanks.
This is Dana, and I'm with the Finance Department for Phnu District. And beginning in January, we looked at additional insurances that we might be able to contract with and bill. Anthem became the service provider for the Kentucky Employee Health Insurance Plan, and so we were realizing that we were going to be working with them more, and also the other insurance, Anthem insurances, that anyone might have, we had decided to start accepting those as well. We were already contracted from several years ago with Bluegrass, and we have continued that. We then, in addition, decided to do Center Care, Kentucky Health Cooperative, and United Healthcare because we were seeing patients requesting our services that had those insurances. And of course, in Humana, we were already had been contracted with previously. So we decided that we would branch out a little bit and see if that would be a benefit to us and to our patients. So the next slide, please. What we have seen to date for this fiscal year through the end of November was that we have had 93% of our claims paid by Anthem and the other Anthem Blue Cross Blue Shield plans. 99.2% of our Bluegrass claims have paid. We actually have ended up not billing anything to Center Care as of yet. Humana claims have declined, but of those, 100% have paid. Kentucky Health Cooperative, which now is in formal rehabilitation and will no longer be serving Kentucky as of 2016. We billed 9 claims to them and only received 2 partial payments to date. For United Healthcare, we haven't seen payments yet, but that we feel like is due to the delay in getting our contract signed. That proved to take a little while. So we're hopeful that as time progresses, we'll see more and more improvement in this area. Next slide, please. The denial reasons that we've seen have been that the patient had not met their deductible, and we had 4 of those. The patient had a copay, and so there was actually no payment provided, and that was 2 people. We had 4 patients who were not eligible on the date of service, and we worked really hard to use Availity and the other websites to check for eligibility on the date of service. We had payment decreased by copay or the deductible, coinsurance, or a combination of those. We had 14 people, and what we do is look at those patients, what their household size and income is, and the percentage that they would pay for what is owed as the deductible or the copay, and we slide that based on their household and income and send them a bill if we see that one is due. In continuing the denial reasons, that we did have some sports physicals, a 4-H physical, and adult physical that was not covered by the plan. And the adult physical was done because the person was going to be a chaperone at a camp, not just a regular adult physical. We had one service that was an immunization counseling on a separate date from when the immunizations were administered, and they did not pay for that service. Fluoride varnish that was done in conjunction with WIC, we had one of those denied. And then we've had a couple of patients who had Medicare as a primary, and then we had to rebill that to Medicare. We had a patient who received other services and then also received a Menactra and Gardasil, and we learned after those were given that that particular insurance company only provided for mandated immunizations. So since these were optional, they were not covered. We had a few issues in the beginning with claims not being received when we thought they had billed out, and then claims not received within the timely filing period. And then we had 4 people who had their insurance company had requested from them other insurance information, and they had not yet responded. And we have been fairly successful in contacting those patients and asking them to contact their insurance company regarding their other insurance information, and then when we resubmit those claims, they get paid. Just a little additional information on the next slide. On occasion, a patient that is an MCO has an MCO and also the third-party liability. So we have to, in order to receive payment or get a denial from the insurance company that we could submit to that MCO, we bill additional insurances that are not contracted. But all of that billing is done at our billing office level. I do that in our district office. Our clerical staff are never responsible for doing any of that type of billing or accepting insurances from anyone that is not a contracted insurance provider. Our next slide is on just a checklist that assists in some valid billing. Just verifying on the clerical level that the coverage is active for the date of service and for the type of service, as we've seen with the Menactra and Gardasil referenced earlier. Making the clerical staff aware when a patient has a non-covered service that their particular insurance does not cover, the 4-H physical or a sports physical or the immunization counseling, so that we are not billing those future visits to the insurance company when they are not covered. And then verifying patient information at every visit, what that patient's income and household number is, the correct address and phone in the event of a copay or a deductible, because that patient is going to be billed on the basis of that information, and we want to be sure that we are billing them the correct amount, whether they owe a bill or whether they do not. We want that information to be correct. And that is all for me, so I'm going to turn this over to our nursing director, Angie Dukes.
Okay, if you want to change the slide, I'm going to talk a little bit about our internal QA audits, some changes we've done, and try to do some outreach internally with all these changes that we've made. So we updated letters that we send to our clients reflecting changes about billing insurance, particularly with our cancer screeners. Our family planners know when they run out of pills, that's pretty much their key to get in, and they know it's time for their yearly exam. But cancer screeners, not so much. So we got a tickler system, and when they're overdue, we will send them a letter. So we made sure that those letters reflected some of the changes that we've made as far as more options for billing and that kind of thing. We updated our family planning patient satisfaction surveys, and of course we shared that with our I&E committee. We have patient community surveys that we issue out to our patients every so often, but we have particular ones for family planning surveys, and it was a 2-page survey. It was full on the front and the back, and that was a little overwhelming, and a lot of them didn't even see the back page, so we condensed it down to 1 page, and I think that will help maybe because if people don't like to do surveys anyway, so maybe that'll be to the point where they'll be willing to fill out more surveys for us, and we can find out from them, get some feedback of what's working, what's not working, and what more changes we need to make. We updated our I&E materials approval form for our I&E committee, and we changed all of our family planning packets and our cancer screening packets, made sure all the materials were in there that needed to be in there. They was updated. Made sure we had the same thing for all 5 counties. For those that work in a district, it's hard sometimes to get everybody on the same page, and sometimes it's just not feasible. But for the most part, we try to make sure, because we got different employees that covers different counties. So we try to make sure we had the same packets, everybody was given the same information, so we got those all updated, and everybody was in agreement on what forms we need to be using for these packets. Next slide. We have a QA team. When we go out and do our different audits, we make sure that we're following policies. We make sure we're doing everything that the Core Clinical Service Guide says we need to do. We make sure we're coding correctly, billing correctly. So to make sure we get a view from everybody's perspective, we got a team together, and it includes myself, and I look more at the nursing stuff, and then you got our clerical supervisors involved, and she's more looking for the clerical things. Finance department, we have a couple that helps us when we do our QA team audits. They can look and see, what should we have retrieved differently that will help them in the billing process. And then if all possible, I recommend to allow your clinic staff to be involved. That has really helped. Sometimes it's not allowable, but just because we have a skeleton crew, and sometimes it's just hard to get them out of clinic, and we have to do this so often. But if all possible, I've got positive feedback that it really has helped, because they get a chance. They're not real keen about auditing their own charts, but it helps them remember things when they are in clinic. They know what the audit tool says and things that they need to do when they're out there seeing these clients, things that we're going to look for and the things that they need to make sure they touch base on. So that actually helps. So I recommend, if all possible, please get your clinic staff involved with your audits. All right, next slide, please. All right, when we do a chart audit, we pull the charts, we pull the PEF for the data service that we're auditing, and we even have the PEF screens in front of us. So we do a complete chart audit. Naturally, we have the audit tools that the Division of Women's Health provides for us to do for the family planners and the cancer screeners. But not only do we do that audit with that tool, we also have our own tool. It's a general medical record review tool. So we check everything from income assessed, copy of Medicaid insurance, Medicare, is it in the chart? Does the PEF match what was entered into the system? Is it coded correctly as new or established patient? Of course, that makes a big difference on what you can bill and get reimbursed. The level of visit, is that appropriate based on your documentation? Is the ICD-10 codes appropriate based on documentation? Is the CPT code matching the reason for that visit and documentation? And then we just do general things like, do they have a master index card on file? Is the allergy label been addressed? So it's a very thorough audit when we do those. It's an all-day long thing with our team. Of course, we do it at least quarterly. We do the 10 family planning mandated ones that we did, the 10 cancer screening charts, and then we go ahead and do all other programs while we're there. So it's a very intense day. Next slide, please. At the end, we allow time to shut the clinic down and allow the whole staff to sit and listen to the review. And that's a great time then to get feedback from the staff and any input that they would have on ways that we can improve further problems that we see we're having when we do these audits. I know every 3 months rolls around really quick and we think, oh my gosh, we just did those and it's time to do them again. But it's good because you catch these trends. If they get, for some reason, they went to bed and slept and thought that they start coding a different code, we catch that and we're like, hey, why are you coding differently? Well, I don't know. I really thought that's what we were supposed to do. I don't know how I got stuck on that. So it's a good way to pull the reins back and say, hey, let's get back on the right track. So that helps. And then at the end, we type up all of our findings and we share with everybody that's needed. And if we think it's something that could be an easy fix, such as just revising a form with common occurrences, we have done that, and that tends to help. If it ain't nothing but changing things around on the H&P form, that's going to come to their attention. If they're forgetting to put, if they've given condoms, how many they've given, we'll revise that form, whatever's going to make you capture that information that needs to be caught. Another example is the PT1, the pregnancy test. That sheet, we have added a place on there for maiden name, and that just helps for like when we work 439E reports for our prenatal logs and for prenatal care tracking. So that has helped capture some stuff. So it's just whatever we can do to keep the process going. And I mean, we've got a lot of changes, but if we're not going to do them right, it's not worth it at the end. So that's pretty much the things that we have done. Next slide, I've got open for questions. We can try to answer those if y'all have any. No?
We're still on. I was muted. I asked a question. Ladies, we thank you so much for doing this. And one thing I'd like to know is, have you seen with the taking of the third-party insurances, are you seeing more clients, more family planning clients, and are you seeing more success in with all the things you've done in getting more revenue into your health department for family planning?
Did you want to answer that, Allison? Okay. I actually asked to see if we could see increase in numbers for the past couple of years. Like I said, this is a new calendar year thing for us as far as the billing insurance and most of these changes we have made. In 2013, we was able to get numbers in 2014, but we weren't able to get accurate numbers for this calendar year because I think Christy was telling me that there is changes in the CPT codings, how they recognize those and everything. So the first 6 months, she was able to give us accurate numbers, but this last part of the calendar year, she wasn't. Right. If we was to project out with the first 6 numbers, we're going to see about a 14% improvement from the last calendar year, which that's what we're hoping we will do.
Well, that's wonderful. And I apologize. I kind of knew the answer to that question, but I wanted the rest of the world to hear that there is an improvement. We can't, because of the new reimbursement policy, we're going to really evaluate that with the first 6 months next month, and so we can give you a little bit more accurate data next month. But it is making a difference, and I just kind of wanted the other health departments to hear that it does make a difference, and so thank you for that. Does anyone else have any questions? Well, hearing none, I will give it back to Ms. Joy.
Thank you to Penny Ryle District and Allison, to you and your team. I appreciate your willingness to present and all of your hard work that you've put into the family planning program, making a success in your district, and the QA process and the quality of care that you provide to your clients. Thank you. Next, if Dr. Poe would come up, we're going to introduce Dr. John Poe. This is a repeat performance of the presentation that Dr. Poe shared at the APRN conference in, was that October? In Bardstown, my old Kentucky home. Thank you. I'm trying to get this away, Joe Allen. Okay, thank you. And I'm going to pull this up here. I mean, this is the beauty, again, I say this almost every ITV, but we've gone now from HCV to family planning and now to animal bites. So always a wide variety of topics and interesting subjects. So I'm going to turn this over, Dr. Poe, to you. There you go. There's your presentation. You just advance your slides right there. And thank you for being with us today.
Thank you, Joy, and I appreciate the opportunity to come to speak to you all here today. And I'm amazed too of the wide variety of topics and challenges that face our state. So, but I really have a pretty good news to report here. Just about 3 reminders. But I just wanted to review very briefly the reporting animal bites requirements in the state of Kentucky. And that's kind of the gist of my conversation here. So with that, I just have a very few slides, and we'll move right on. And the basic objective of me here today is to remind the local health departments, to remind providers that reporting animal bites in Kentucky is a statutory requirement by a KRS that's actually in the Kentucky Department of Agriculture. And normally our healthcare reporting requirements are in administrative regulation. This one is not. And it was created in 1954. And KRS 258 says that healthcare providers will report animal bites to the local health department within 12 hours or the next business day. The thing that's interesting about this is that this Kentucky statute is administered by the Cabinet for Health and Family Services, which makes this a little bit challenging to administer because it's technically an agriculture statute. Again, it's in statute. We can't amend it. We can't adjust it. And it's a Kentucky Department of Agriculture statute, so it's hard to get them to modify it. But it is what it is, and it's our job in the Cabinet for Health and Family Services to administer it. So that is what I'm here to doing today. The best patient care, and the reason why do we have KRS 258, which was created in 1954, was really to prevent the risk of rabies transmission to the human population. In 1954, things were very different than they are in 2015. We didn't understand nearly as much about rabies, the transmission of rabies in relation to animal bites. But in 1954, this law was created to assess the risk of rabies in the human population due to animal bites. So they created the law that says animal bites will be reported to the local health department by the healthcare provider or responsible adult. And the local health department environmentalists are allowed to search, identify the biting animal to eliminate the possibility that rabies could be transmitted. And the whole purpose of that 10-day quarantine is to exclude rabies from consideration in the reported animal bite. Okay, so because the public has a wide perception about rabies, and a lot of times you have to kind of truncate their thinking because the appreciation is probably it's blown out of proportion sometimes. So we have to truncate the conversation and the risk of rabies transmission in animal bites, especially with dog and cat bites in Kentucky. But basically, with an animal bite report form, there's kind of 3 critical pieces of information. And the first one is the person bitten and contact information, including a parent or guardian if it's a child. And as many of you all know, there's a lot of animal bites in the pediatric population. So that the person that was bitten, all of the contact information should be reported. And obviously this includes HIPAA protected information, so the animal bite report form should be faxed to the local health department. In the second part of the animal bite report form is basically a basic description of the animal. Who was it that the person bitten was bitten by? Dog, a cat, a mouse, whatever. And sometimes we get, people don't know, and it's funny to follow up on some of these sometimes. Sometimes people really don't know what kind of animal it was. But finally, the third piece of information is the suspect animal owner. And oftentimes the person bitten identifies the animal quite clearly, quite conclusively, and the probable owner. But all that information is really required, it's needed for the local health department to follow up, and it is a lot of information. So after the animal bite is reported to the local health department, really what goes on there? And basically a 10-day quarantine is, we try to do a 10-day quarantine on the animal that did the biting. And as we do this, as we go through this 10-day quarantine, we observe the animal on the first day, and then we observe the animal on the 10th or day or so after that. And what we do by observing that animal is we say that he is normal, he has not died, and we exclude rabies as a consideration. So the real practical benefit of the 10-day quarantine is to rule out rabies as a consideration and prevent the need for rabies post-exposure prophylaxis, which is the human medical treatment for the prevention of rabies. And rabies PEP is a 2-week medical treatment. It's relatively expensive. Some of the part of the product is in short supply. But by doing the 10-day quarantine, by reporting the animal bite to the local health department, we can accurately assess the need for rabies PEP. So that's the whole point of what we're doing. When animal bites aren't reported in the normal route, when healthcare providers treat animal bites and avoid this process or do not follow through, oftentimes the attending physician, healthcare provider, nurse will initiate rabies post-exposure prophylaxis, which is expensive. So the whole point I'm trying to make here today is if we report the animal bite to the local health department and allow this investigative process to unfold, we can actually improve patient care by eliminating the unnecessary use of rabies post-exposure prophylaxis. Okay, I've really already covered this. And the real story on animal bites and the real risk of rabies and the need for rabies post-exposure prophylaxis has really improved. We've come so far in the last 61 years since our rabies law was created. But in reality, in 2015, the state health department will be contacting healthcare providers if, in fact, there's a risk. So the information is flowing really from the state because we're going to have a diagnosis of rabies in an animal, in a bat, perhaps in a skunk, or perhaps in an unvaccinated dog. We're going to have that information coming in. So the information it'll flow 2 ways. It will flow from the person bitten to the local health department, and in another direction, it will flow from the state health department to the local health department and to the person that was bitten, to the provider, if in fact it's a high-risk situation. So it's really the 2-way flow of information is really 2 safety nets. The first is the reporting of the animal bite, which is the safety net of observing the animal. Is there a need for rabies PEP? And then finally, the second safety net is that the state health department will be contacting the person bitten, the parents of a child that's bitten, and also the health care provider. So the high-risk situations in the state of Kentucky, we will be following up, which is an important message to get across. Oh, and the third, probably the final point I want to make, if rabies post-exposure prophylaxis is initiated, if it's done by any healthcare provider, it is a reportable condition according to our administrative regulation. So if a nurse practitioner, if a physician initiates rabies post-exposure prophylaxis in an outpatient setting, they should report that to the local health department via the NED system. So, and the purpose of that is to really, for the local health departments or the district health departments, to really assess the rabies post-exposure prophylaxis usage in their state or county, and to really assess kind of, is this, all of this really needed? Real quick, and we talk about animal bites, the real story in 2015 is we know a lot about rabies, we know about how it's transmitted, we know where the reservoir species of rabies is, and very specifically, rabies in the human population, the transmission are bats. This is actually a graph of 57 years of human rabies fatalities due to bat rabies. And if you look at this map here of Kentucky, we actually have it's actually three. And since we've had a human fatality in 1973, 1979, and 2006. So the real risk in the human population is bat exposure. Okay, a lot of times people have exposures to bats and they don't report a bite. So the challenge with preventing rabies and talking to rabies to the human population is that we need to tell the message that the real risk are bats. Bat exposures, unrecognized bat exposures. These are the recent human rabies fatalities. I should really redo this slide. It's all of the human rabies fatalities that have ever been documented. We actually had 2 rabies fatalities in 1961. In the central part of the state, there was actually a fox variant rabies going through the country, as a matter of fact, but it died out. And the real challenge in talking to people about rabies is you have to drill down into pretty specific details. And we talk about different rabies virus variants. That's because it affects the picture completely. And so as we talk about where do these people get rabies, we will tell you that it was a fox variant of rabies. So, and that is no longer in our state. Okay, so we come right down to 1973, 1979, and 1996. These are the last 3 human fatalities that are reported by Kentucky. And as I said before, they are bat variant. So the human rabies information tells us that the risk are bats, very specifically bats. Okay, the challenging things about dealing with animal exposures, the real risk of rabies in the human population are bat bites. And this is a slide of a documented bat bite. And if you look at the top slide, you'll look at a finger there, and on about the 4 centimeter mark, you will notice 2 diagonals or 2 small white lines, and that is the actual canine teeth of the bat bite. And this is just another picture a few minutes later. This is a documented bat bite, and this is the real risk of rabies. It's actually skin punctures. It's nicks. And this is the animal that is high risk for rabies in the human population. So the message going forward, don't touch the bats. Don't touch the bats. That is it. I thank Joy Hoskins for the opportunity. Questions, please.
The man that died in 1979 was my neighbor. That was a huge thing out in Baltimore.
So you remember that?
He says nothing touched him.
Well, I've read the medical history of that case. The man was very outdoors. He was farmed. He was a hunter. He was outdoors. And so you say, where did that exposure come? There's only 2 possibilities. It's bat or skunk. well, there's never been any skunk variant rabies in Franklin County. So it's bat.
So after all these years, I can finally go back to Walnut and say,
Yes.
it was a bat.
It was a bat. It was a bat.
And we can all live safer.
That's good that you remember that. That's
We've
so.
been scared of everything.
But that person didn't pick up on, he was probably out in the woods and put his hand up somewhere, and a bat, there's been a slight brush with a bat. And that is consistent with all the other human rabies fatalities.
Are bat exposures seasonal?
A little bit, because bats will go in what we call hibernation or torpor during the winter months. And now, as the weather gets cold this winter, they will do their torpor, which is their hibernation phase. So they will be looking for a quiet, dark place away from everybody to do their torpor. So yes, we don't have many bat contacts in the middle of the winter, January, February, March. When the bats become active is when the insects come out. It is seasonal. So in the spring and summer, when the insects come out, the bats come out of their torpor, they're looking for insects. That's when we see bat activity, we see bat-human interactions, and that's when we see the positive bats come in. Good, excellent question.
Any other questions from the field for Dr. Poe? Okay, thank you, Dr. Poe. Appreciate it. Appreciate your time and support. And Dr. Poe, I forgot to mention earlier, failed to mention, he's our state veterinarian, serves in that capacity. He's a one-man show. Anything about animals, animal bites, cows, horses, dogs, he does it all. So I think everyone knows Dr. Poe, but thank you again for presenting to the nurse leaders, Dr. Poe. Appreciate it.
Thank you.
This is Ava. Can I ask a quick question?
Dr. Poe? Sure.
We were just talking here in our room. So rabies is just carried by the bats. The bats don't actually die from the rabies, correct?
Yeah. Let's get Dr. Poe in here, Ava, and we'll
I'm
clarify
sorry.
that. That's okay. That's okay. You caught him just in time. The question is, bats carry the rabies. They don't die from the rabies.
Well, that's a good question, and it's kind of complicated to answer. We know that rabies perpetuates itself in wildlife species and has for millions of years. What it does in bats and other terrestrial animals like skunks in some Kentucky counties is that it circulates and doesn't kill the bats. Some bats may die, but what it does, it actually circulates in the bat populations from bat to bat when they move out in the spring and summer, and it's perpetuated, and those animals don't die. So rabies is perpetuated in wildlife species by slow transmission in their colonies. And if we talk to the people that really know a lot about rabies now, it's USDA Wildlife Services, and they can show, if they go out and start trapping bats in very natural settings where they actually capture the bats that are flying, they can show that probably 15 to 20% of the bats will show positive antibody levels to rabies virus, which means they have been exposed, they are developing antibodies, and they get over it. So bats are always a high-risk animal. Rabies is circulated in their different species for a long, long time, so they will always be a risk.
Does that answer your question, Madison County?
Yes, it does. Thank you very much.
Sure. Any other questions for Dr. Poe? All right, thank you.
Good question.
All right. All righty. Let's see here. Next, Troy Cunningham, my friend, is going to come up here and provide us a brief update on influenza, talk about the state's influenza activity level, and share some information with you. You know, this is an annual presentation, And so, Troy, I appreciate you coming and sharing this data and information and updates with the local health department nurse leaders. Thank you.
Good morning. Again, I'm Troy Cunningham. I'm the nurse consultant and the influenza coordinator and adult vaccine coordinator. Today I'm talking to you about influenza. The diagnosis and the method is very important for us to be able to see what's going on in the community and what's truly happening out there. You want isolation of the virus from a clinical specimen from the nasopharynx, throat, or sputum. The viral culture or PCR is preferred by the CDC. Most offices use rapid testing. There is some controversy about that. The CDC doesn't actually use those as confirmatory tests, only the PCRs, but they are very valuable for treatment. And the serologic testing, which is actually pretty much not useful at all. That is testing antibodies, and so that is either going to be looking at the fact that they've been exposed and they're developing antibodies to that virus, or they've received vaccine and it's working. So the serum testing is not a useful tool at all. Rapid tests performed in clinical settings vary in sensitivity, and they can actually provide false negative results is the problem. They're useful for initiating timely treatment, and the sensitive PCR testing is only likely to detect influenza if it's performed within a week after onset. Now, you can still send it in, and it still may be possible, but that's your best window. PCR testing also has to be performed by either a reference laboratory or the state laboratory. There were some changes to the 2015-2016 vaccine. As you've heard, there was a lot of press about the vaccine not working very well. Actually, in Kentucky, our rate of match was much better than it was in other parts of the nation. The trivalent vaccine means it has 3 different types of flu virus in it. The H1N1 California strain remained the same this year. The CDC changed the H3N2 strain. It was formerly the Texas strain, and that was changed to Switzerland. One strain of the influenza B virus, which was Massachusetts, was changed to Fukit. Both of those are Yamagata lineage. The quadrivalent vaccine has the first 3 that we've just discussed, but there is an additional influenza B virus in that vaccine. That remains the Brisbane Victoria lineage. Lab data so far suggests that most viruses circulating are matching well. We want to make sure that people are vaccinated to prevent the flu and receive antiviral therapy to treat illnesses. That is the 2 most important medical countermeasures that we can recommend. Flu season in the southern hemisphere is from May to October, kind of our off season. And so we can see how the new vaccine is actually working by seeing what's happening over there. And so far it looks like everything's pretty good. So how does flu spread? I love this picture. It's respiratory transmission of virus. It's very contagious. It's droplets when you cough or sneeze, and there's a perfect picture of our droplets there. Viral shedding. The virus can actually be present for 5 to 10 days after the onset of symptoms. And then the third is fomite transmission, and that is contaminated surfaces or objects. Thinking about door handles, elevator buttons, phones, countertops. The fomite transmission can actually last 2 hours after the droplets hit that surface. So, it's not always just about being in the line of fire when somebody sneezes or coughs. We know the symptoms of flu are headache, tiredness, fever, runny nose, cough, sore throat, and body ache. Some people actually have nausea and vomiting as well. The important thing is to cover your nose and mouth with your elbow or tissue, to wash your hands thoroughly, and to disinfect surfaces. So, activity recommendations from the CDC say that if you're sick with a flu-like illness, you're to stay home at least 24 hours after the fever is gone, except to get medical care or other necessities. And that fever should be gone without the use of a fever-reducing medicine. And a lot of people don't necessarily follow that guideline. And of course, while you're sick, limit contact with others as much as possible. We know that there are a lot of employers that don't take it too kindly when you stay home because of the flu, but in actuality, it's to their benefit as much as anybody else. A flu-like illness is determined as a temperature greater or equal to 100 degrees Fahrenheit and a cough and or a sore throat without any other known cause of the infection. Currently, we have 97 influenza-like illness surveillance sites across the state, and so that is urgent treatment centers, doctors' offices, university campuses. That gives us an idea when they report weekly their influenza-like activity into the CDC. It gives us an idea, a picture of what's happening across the state. Of course, the treatment is going to be antiviral medications. We commonly use the term Tamiflu. There are some other ones that are out there. They're available by prescription only, so don't be confused if somebody says there's something over the counter that's similar. It's not. Antibiotics are used to treat bacterial infections, not viruses. So, don't try to convince the doctor that you need an antibiotic because it's not going to work. Antivirals are not a substitute for receiving the flu vaccine, and the earlier the better with taking antivirals is going to be your best bet. If they're started within 2 days of symptom onset, it can be beneficial up to 5 days after getting sick. So definitely, if you get the Tamiflu, take it, and take it as prescribed. One of the big issues right now is flu vaccine in pregnant women. A pregnant woman getting the flu vaccine is a very, something that we really want to stress. A lot of practitioners we're finding are not making a strong recommendation to get that. This population is at the highest risk, one of the highest risks of hospitalization, severe illness, and death related to flu. By the mother getting the vaccination, she can protect the newborn baby 6 months after it's delivered because they're not able to be vaccinated until they're 6 months of age, and that's called a cocooning immunity. And flu vaccine can be administered in any trimester. So it is very important that we try to make sure that those we know that are pregnant receive their flu vaccine. In healthcare personnel, this is probably the biggest group on who needs to receive the flu vaccine. We see that according to the CDC, there are some kind of disturbing numbers about how many healthcare personnel actually receive the flu vaccine. It looks like pharmacists and nurses do a pretty good job. Physicians do a pretty good job. Where the most startling number and most concerning number is in assistants and aides. They're the ones that are more likely going to have, patient contact, and they're the lowest percentage of the frontline healthcare employees that get vaccinated. So that's something that really needs to be looked at, and, that's something to concentrate on in your, not only in your clinics, but to reinforce with doctors' offices and long-term care facilities. The Influenza recommendations by the ACIP had some small changes for 2015-2016. There's no longer a preference between the inactivated influenza vaccine as the injection versus the live attenuated influenza virus vaccine, which is the nasal spray. That's for all healthy people without any sort of contraindication or precaution from ages 2 through 49 years of age, as long as it's an age-appropriate formulation and dosage. So last year, they were really recommending the nasal spray more so for children than others, and this year they're saying it's all good as long as you get one. So, children ages 6 months through 8 years who have previously received greater than or equal to 2 doses of trivalent or quadrivalent before July 1, 2015, require only 1 dose of vaccine in 2015-2016. The 2 previous doses do not have to have been given during the same or consecutive seasons. Children ages 6 months through 8 years who have not previously received a total of 2 or more doses of trivalent or quadrivalent before July 1, 2015, require 2 doses in 2015-2016, and that interval between the 2 doses should be at least 4 weeks apart. The live vaccine, which is the nasal spray, should not be used by people less than 2 years of age or greater than 49 years of age, people with contraindications that are listed on the package insert. That would include people receiving aspirin or aspirin-containing products, if they've ever had a severe allergic reaction to a vaccine or any of its components. Pregnant women should not receive the live vaccine. Immunocompromised people or those with a history of egg allergy. Children ages 2 through 4 with asthma or who've had a wheezing episode noted in their record in the past 12 months should not receive live vaccine. And persons who have taken influenza antiviral meds in the past 48 hours should not receive live vaccine. So the takeaway points here are that everyone 6 months of age and older should get their flu vaccine annually. Pregnant women should get the flu vaccine themselves to protect them and their newborn the first 6 months of life. And children younger than 6 months of age are at high risk of flu illness, but too young to get the vaccine. So it is very important that if you are a caregiver to an infant younger than 6 months of age, you too should make sure that you get your flu vaccine. Vaccination is especially important in healthcare workers and others that care for people at risk of serious complications and try to avoid contact with sick people. Now, in Kentucky, we are seeing a rise in the influenza-like illness. So far, we've only had 13 as of last week. We've only had 13 confirmed PCR cases. But there is a lot of the influenza-like illness out there being shown by rapid testing. So things are starting to pick up. We anticipate that the Christmas holiday will, once everybody gets together and goes circulating to Grandma's house, we feel like everybody's going to come home with some extra goodies in their bag. So just please try to make sure that, that you do get your vaccine, that you promote it with your family, and good hygiene. Now, one of the biggest co-infections with influenza is pneumonia. And so the Department for Public Health recommends that all adults 65 years and older and those in high-risk groups receive a pneumococcal vaccination. And preventing bacterial complications of flu and pneumonia is of significant importance during the flu season. In Kentucky, we had 92 outbreaks of influenza-like illness and pneumonia in 2014-2015. So last year we had 92. The year prior to that, we had 11. So there's obviously some really big problems there. Nationally, the hospitalization rate for those with influenza or pneumonia was 183.2 per 100,000. And then last year, it went to 319.2. That was the highest rate since surveillance had been started in 2005. So obviously there's a huge problem. The deaths in the age of 65 and older exceeded epidemic threshold for 8 weeks in January and February of 2015. So very, very, very important that we take care of our people in the long-term care facilities. We really do not want to see 92 outbreaks this year. So there are some recommendations for pneumococcal vaccine. Nancy's going to go over this in more detail because it is being switched in the CCSG. And so she'll go into it a little bit more in depth in just a minute. Essentially, a healthy adult that is 65 and older who has never received a pneumococcal vaccine should get Prevnar 13. At least 1 year later, they'll get Pneumovax 23. If they've received a Pneumovax 23 before the age of 65, now they'll get a dose of Prevnar 13 at least 1 year after the Pneumovax 23 dose. They'll need another dose of Pneumovax 23 at least 1 year after the Prevnar, and the 2 doses of the Pneumovax should be at least 5 years apart. They definitely did not make these recommendations easy to understand. On the schedule for those under the age of 65, routine vaccination of all healthy children aged 2 through 59 months with Prevnar 13. The schedule is at 2, 4, 6 months and at age 12 to 15 months. If the children have not received the 4-dose series and they have been previously unvaccinated, age 7 months or older, you should consult your pink book in the appendix A4 that shows a catch-up schedule, or you can look at cdc.gov vaccines under pink book and find it there, or immunize.org, or you can call your friendly immunization staff. Okay, so pneumococcal vaccine for those 19 years and older with immunocompromising conditions. They should receive the Prevnar 13 to anyone that is eligible, in addition to the Pneumovax 23. And here is a list of references on all of the information that I've given to you today. Here's my contact information if you have any questions. And if you didn't, or those you love, did not get your flu vaccine, we hope that you get well soon. And I hope you all have a Merry Christmas.
Thank you, Troy. Very important information. Thank you for sharing that with us today. We are out of time. We've used up our 3 hours, so I understand we still have probably about 10 to 15 more minutes of presentation. So if you can join us, we'd love to have you. We'll keep on recording. The information that we have to share for the last portion of our agenda is related to the CCSG revisions and updates. Certainly this session will be archived as well, so if you need to leave, get back out to clinic or whatever, please feel free to go ahead and do so, and this information will be available, as I said, through archive webcasts, and you'll be able to use this for your staff training. If you can continue to join us, thank you very much, and we apologize for running over a little bit later. We had some great questions regarding the new hepatitis C program, implementation of that program, and so that pushed us over just a little bit. So thank you to Nancy and Julie as well, and Troy for hanging around. Let's see here. Which one do you want to do first, Nancy?
That one. Yes.
PCV? Okay. There you go. You're all set to go.
Thank you, Joy.
You're welcome.
Happy holidays, everyone. On, as Joy said, that this will be on the CCSG information, but on the pneumococcal, what I did was just do what the changes are. Am I supposed to be looking at somebody?
The camera's right there.
Hello. Hello out there. Okay. I didn't know if I should or not. Okay. So our changes on the recommendations for pneumococcal 13 and PPSV 23 are, as Troy said, are a little bit difficult to understand. But what the ACIP wanted to do, was to try to make it more easier to follow schedule. So what they wanted to change was the 6 to 12 months to a year for adults over 65 years of age. The recommendations for all other intervals for those did not change at all. But these two, they changed to the 6 to 12 months to a year, and then 5 years between the two PPSVs. So they tried to simplify it, and as Troy said, it's still a little difficult to understand, but hopefully I've put in some graphics for you that will help you to understand that. If the two vaccines, the PCV and the PPSV, cannot be co-administered, they need to have that guideline, that interval between them, and if the PPSV is given before it should have been, do not repeat it. So as I said before, the CDC just wanted, and ACIP just wanted to recommend a change for harmonization between the two. So this is our first diagram, and this one is really pretty easy to read, and if you could maybe make a copy of this and keep it close by, so you would know. It shows that there's a year between the PCV 13 for people over 65 years of age until you take your PPSV 23, and this is for people who have not had the vaccine. For people who have previously received PPSV 23, again, you wait a year, give the PCV 13. Now, people who have previously had PPSV 23 before 65 and are now age 65 or older, if they've already received the PPSV 23, you wait a year, give the PCV 13, you wait a year, and you get the PPSV 23. But you have to make sure that there's 5 years between the two PPSVs. So I think this is a good format to follow and would be good for you to make a copy of and keep where you keep your other cheat sheets. The other page is just footnotes that you can read for sake of time. You can just read those. This is another formatting summary of how to give the PCV and the PPSV when at different ages and for different underlying chronic conditions. I'll let you all read these. If you have any questions about these, feel free to call me or to call any of the nurses in the immunization program. Again, just another formatting issue. Okay, so there was a problem with the pneumococcal, the PCV 13 package insert that said that for adults, antibody responses to Prevnar 13 were diminished when given with the flu vaccine. So Ask the Experts told us that no, that's not true. The available data have been interpreted that any changes in antibody response to either vaccine's components were clinically insignificant. So therefore, you can, don't worry about that. Just go ahead and give your immunizations. And if PCV 13 and influenza vaccine are both indicated and recommended, they should be administered at the same visit. The PCV 13 can be administered with other vaccines, and in drug interactions, or if I'm sorry. In adults, the responses with the PCV13 were diminished when given with inactivated trivalent influenza vaccine. There is no true waiting period between inactivated influenza vaccines and the PCV13 vaccine, as both are inactivated vaccines, so you don't have to have that 28 days in there. However, if they're not given at the same visit, just for fun, we should give them at least 5 to 7 days apart, if not given at the exact same visit. And that would enable any perceived and immediate adverse events to possibly be identified as to which one they came from. Okay, references. This is all in the CCSG, and you've all received this, has just gone out, so all this information is there. And if you have any questions, feel free to call. We don't mind to answer your questions. Okay, and I want to spend just a little bit of time, maybe a minute or two extra, on the Bexsero and Trememba because they're new. Thank you, Joanne. There you go. Thanks. All right, we have 2 new immunizations out there, and I know you all have been aware of them. I think you've even purchased some, but now we've got the CCSG to go with them, and you can actually be giving them. This is recommendations for meningococcal group B vaccines. They're MenB, Bexsero, and Trememba. Okay, MenB vaccines are for Neisseria meningitis serogroup B. These are different from regular MCV vaccines. These are for serogroup B. MenB vaccines are recommended routinely for the use in individuals that are aged 10 years and older. If you'll combine the two bullets, for people who are at increased risk for meningococcal disease attributable to serogroup B. Okay, MenB vaccines may be administered to adolescents aged 16 through 23, if you combine the two, to provide short-term protection against most strains of the serogroup B meningococcal disease. There is no preference for either of the MenB vaccines, Trememba or Bexsero, but they do recommend that the same vaccine product be used to complete the vaccine series because the vaccines are antigenically different. Both MenB vaccines for FDA-approved use in persons aged 10 through 25 years. Now to break down the difference between the two. Bexsero is a 2-dose given at least 1 month apart on a 0 and 1 to 6 month schedule. They should be only given in the IM in the deltoid muscle of the arm. Trememba is a 3-dose series, and it can be given on a 0, 2, and 6 month schedule. Again, IM deltoid muscle of the arm only, and MenB vaccines can be administered with any other vaccine. It doesn't matter as long as they're given at a different site. As long as the other vaccines are given at a different site, those have to be given in the arm. Okay, I won't go through this. Once again, you have this through your CCSG too. It's just another formatting, dosing schedules for age groups and which vaccine and the routine recommendation for it. Again, same thing. Eligible groups for the high risk are children and adults aged 10 years or older at increased risk for meningococcal disease attributable to serogroup B, including. I won't read these to you because they are the exact same people that are in the first that are usually included in all of our high risk groups. They do have a couple that are added as the microbiologists that are routinely exposed to Neisseria meningitis in the laboratory, and persons identified to be at increased risk because of an outbreak attributed to serogroup B. Low risk are children aged 16 through 23 years without high-risk conditions with a preferred vaccination age of 16 through 18 years. Contraindications for these are severe allergic reactions after a previous dose of Trememba, hypersensitivity, including severe allergic reaction to any component of either of the vaccines. Fainting may occur in association with administration of Bexsero, but they did not mention fainting with Trememba. I don't know. Bexsero may not protect all vaccine recipients, and Bexsero may not provide protection against all meningococcal serogroup B strains. So these are warnings and precautions only. Individuals with altered immunocompetence may have reduced immune response to Bexsero. Epinephrine and other appropriate agents used to manage immediate reactions, allergic reactions to these drugs must be immediately available if given Trememba. Individuals with altered immunocompetence may have reduced immune response to Trememba, just as Bexsero. And latex-sensitive individuals for Trememba, on the pre-filled caps, they are not made with the natural rubber latex and may cause allergic reactions. Men B vaccines should be used during pregnancy only if clearly needed. There is a pregnancy registry that is available online for women who receive Bexsero during pregnancy, and you can contact Novartis Vaccines at the number listed to be on that pregnancy registry. Caution should be exercised when Men B vaccine is administered to nursing women, and safety and effectiveness of Men B vaccine in children younger than 10 years of age have not been established. Therefore, you should be cautious when you give the drug to a nursing mother. The safety and effectiveness of Men B vaccines in adults older than 65 has not been established at this time, and Men B vaccine is not currently recommended for persons who travel or reside in countries where meningococcal disease or hyperendemic or epidemic, because there is the risk for that, for Men B disease in those countries, is usually it's not caused by the serogroup Bs. Okay, provide language and appropriate VIS statement for patient counseling prior to the administration of these drugs, of these vaccines. The healthcare professional should give or explain the importance of completing the 2-dose or 3-dose, 2-dose for Bexsero, 3-dose for Trememba immunization series, and do it with the same brand. Do not switch the brands. Report any suspected adverse reactions to a healthcare professional, and register women who receive Bexsero while pregnant in the pregnancy register. And individuals with altered immunocompetence may have reduced immune responses to the Men B vaccines. There's your references. Any questions? Feel free to contact me. I don't mind at all, as the rest of the nurses in the program, they don't mind either. For sake of time, if you would email your questions to me, I will make sure that they get out. The answer and the question are sent out to everybody. So thank you all for allowing me to give these updates, and thank you, Joy.
Sure.
Happy holidays, everyone.
Thank you, Nancy. Julie, you want to come on up? How you doing? Good. Let's see. Let's see here. I think. Let's see here. There you go. Next, I'd like to introduce Julie Miracle, who's a nurse in the immunization branch. She's our perinatal Hep B prevention program coordinator, and she's going to be presenting CCS changes regarding the the Hep B immunization. Thank you, Julie, for joining us.
Good afternoon, I guess now. Happy holidays, everyone. Thank you for having me. I'm just going to give a very quick update on post-vaccination serology and how it affects the perinatal hepatitis B case management program. We all know that infants that are born to mothers that are Hep B positive have a greater chance of becoming hepatitis B positive and having chronic infection related to the vertical transmission during delivery. And that these infants are the infants that we need to protect with the Hep B vaccination and HBIG at birth, and then continue the vaccination and complete series by 6 months of age, and they need post-vaccination serology. On October 9, 2015, the MMWR was released stating shortened intervals for post-vaccination serology testing for infants born to the hepatitis B infected mothers. With this, what are the shortened intervals was that serology testing should be completed at 9 to 12 months, or at least 1 to 2 months after the final dose of vaccine series if was delayed, instead of 9 to 18 months of age. What does the post-vaccination serology need to include? It needs at least the hepatitis B surface antigen and the quantitative antibody to the surface antigen. So when your providers are ordering the test, make sure that they don't just order acute panels. They need to include those two tests. The acute panel does not include the quantitative antibody to the surface antigen. The infant needs to be at least 9 months of age. If you draw it earlier than that, the HBIG sometimes will be still circulating, and sometimes you can get a false positive. Also, it must be done at least 1 to 2 months after the last dose of vaccine. If you do it before 4 weeks, you can get a false positive from the vaccine. And then 1 to 2 months because of the other case management programs, the perinatal case management, that has shown that the best time for the outcomes is that we get the best antibody responses, and that is why they decided to move the intervals up to 9 to 12 months of age. This here is our resources. That is the MMWR, and this is the perinatal hepatitis B programs. They have a lot of resources on there, so that if you need teaching sheets, need any kind of resources for the CDC perinatal hepatitis B program, there's resources there for teaching parents. And that's my contact information, and that's it. And it was a very short.
That was short and sweet. You were right, Julie. Thank you so much for presenting to the group. Appreciate it. Okay. I am going to wrap up here, folks. Just have 2 short presentations left. The first one is on the emergency chapter. Thank you to Lisa Heck for pointing out to me that the link for the O2 flow rate recommendations was no longer working, so I mentioned this, worked with Dr. Brawley, and he found another website link that does work from the American Red Cross Association, and it does give some great guidance about administering O2, especially in an emergency situation. And so that link, the hyperlink that was previously in the emergency chapter, has now been updated. That was the only change to the chapter. And the next one. The next one is about naloxone protocols, specifically in the school setting. That will be added as a appendices B in the CCSG document. Senate Bill 192 added language about naloxone for schools, and it said that each school board may permit a school to keep naloxone on the premises. and regulate the administration of naloxone to any individual suffering from an apparent opiate-related overdose. And so then in collaboration with local health departments, local schools and school districts, DPH developed a naloxone protocol specifically designed for in the school setting. And so that protocol was written. Susan Lawson in the school health program wrote that in conjunction with Dr. Humbaugh, and that will be housed in the CCSG appendix section. Other partners that were included in that writing of that protocol included maternal and child health staff, Kentucky Department of Education. So KDE should be familiar with this protocol. It was shared. As I said, they will participated in the writing of it, and that protocol has been shared with KDE. And the Department for Behavioral Health and Intellectual Developmental Disabilities also participated and contributed to the protocol. So there are the components of the protocol: risk factors, signs and symptoms, administration, indications and usage, how naloxone is supplied, storage and handling, and then responding to an opioid overdose. So that, and the references as well. So that information is all included in the protocol. As I mentioned, Susan Lawson was the lead author of that protocol. So if you have any questions, please contact her. The role of the local health department in distributing this protocol is if you do partner and collaborate with and have a contract with your local school systems, you may want to provide this information to them, let them know that it's now available for their use, and they would be able to work with you and partner with you as far as any consideration and dialogue about the implementation of this protocol. Certainly, if there's requests from your community to provide or share this protocol with them, please feel free to do that as well. As I said, it's an optional protocol for implementation for the schools. So from the standpoint of the local health departments, it will be housed in our CCSG per the statute, and just the partnerships and communication and providing that protocol to them. That will be our role from the local health department perspective. Any questions about the emergency chapter changes or the Appendix B naloxone protocol? Okay, I did attach with the agenda the 2016 dates for these public health nursing ITV. February 18th will be our next ITV, so please mark your calendars so we can continue to provide information and training updates to you all. Thank you for everything that you do for public health. Couldn't do it without you. You all are doing a fantastic job. And Merry Christmas, and we'll see you in February. Thank you.